All right, the sacrum, the scary little sacrum. Sacred bone, that's where the name comes from, because it's so important in supporting our body. So we need to look at the motions of the sacrum. And it's interesting that some of the motions are, shall I say, theoretical still. The sacrum has so many little facets inside the joint that people have yet to identify what is a normal sacrum. Okay, we have identified 3 axes of motion that are definitive. Some other axes of motion are still somewhat theoretical. So even some of the things that I show you today in terms of sacral motion is still a little controversial. I'm back to the same issue of, if that helped my patient and I saw a functional change on the table, I'm good to go, and we can worry about proving the theory later, but as long as it works. We're going to look at some of the palpation of the sacrum. We want to make sure that we identify the areas that we will palpate in order to get our somatic dysfunction diagnosis for sacral somatic dysfunction. Of course, you have the posterior superior iliac spines, PSIS, the most obvious bony prominence right next to that dimple there. If you bring your finger palpation just medial to the PSIS and a little bit superior, you're in the sacral sulcus. It feels like a little dip or depression that your fingers sink into, and it should be symmetrical on both sides. Both should be symmetrically deep. If they're asymmetrical, that's telling you that there is a sacral dysfunction. Palpate also the spinous processes of the sacrum in the midline. If you come down below the 3rd spinous process and a little bit inferior, you could find these inferolateral angles of the sacrum, the ILAs. Inferolateral angles are supposed to be symmetrical. If they are asymmetrical and one side is prominent, we consider that the problem side. Likewise, with the sacral sulcus, they should be symmetrical. If one side is prominent, we would consider that the problem side. If the problem sides of sacral sulcus being prominent and sacral sulcus being deep and ILA being prominent on the same side, it's a flexion or extension dysfunction. If the sacral sulcus is deep on the right and the ILA is prominent on the left, that's more of a torsion dysfunction. So we're going to use palpation of sacral sulcus and ILAs and their relative positions in neutral and in extension to determine what is the position of the sacrum in terms of its somatic dysfunction testing. And just to review again, sacral flexion is a forward motion, anterior motion of the sacral base, and that occurs in combination with lumbar extension. Sacral extension, or a posterior torsion or backward torsion. Sacral base moves posteriorly and the lumbar spine flexes relatively. So you have those combination reciprocal motions. As the sacrum flexes or nutates, the lumbar spine extends. As the sacrum extends or counter-nutates, the lumbar spine flexes. So those are our motions of the sacrum. There are considered 3 main axes of the sacrum, superior, middle, and inferior. There's a left oblique axis that goes from the left sacral sulcus to the right ILA. There's a right oblique axis that goes from the right sacral sulcus to the left ILA. And there are motions of the sacrum about these oblique axes as well. There are other theoretical axes about the sacrum that I'm not going to cover right now, but those are the main ones that help us determine anterior and posterior positions of the sacrum, or flexions and extension dysfunctions, and rotation side bending combinations, which are considered the sacral torsions. If the sacral base, which remember is the superior aspect of the sacrum, moves anteriorly, okay, if it moves anteriorly, that's called sacral flexion. Now, if you notice, if you flex the sacrum, what relatively happens to the lumbar spine? It extends. So there are reciprocal motions of the lumbosacral junction, and anytime the sacrum flexes, the lumbar extends. If you think about problems where one SI joint may be locked or hypomobile, you're going to see that that reciprocal motion is impaired, and the patient might end up having pain at that joint, or you're going to see that there is asymmetry of the sacral sulcus, side to side, and the inferolateral angles. And that's key to what we're going to use for diagnosing somatic dysfunction of the sacrum. Sacral extension. The base of the sacrum moves posteriorly. So what do you see happening to the sacral sulcus when the base moves posteriorly? Is it prominent or deep? becomes prominent. So if you find prominent sacral sulcus, you can say, okay, we have an extended sacrum. If you find a deep sacral sulcus, oh, okay, that is a flexed sacrum. Then that's some of our diagnostic indicators, and you'll see that sometimes it could be flexed on one side, extended on the other side, or flexed on both sides, extended on both sides. And then there's also aspects of side bending and rotation combined that we call torsion of the sacrum. So the sacral torsions come about on these oblique axes. So if this is the, and I'm matching it with the sacrum here just to make sure you have it in your mind's eye. There's the sacrum. If this is the left sacral sulcus and right sacral sulcus, you might even want to note that on your page just so you know what these edges of the page are referring to. They're your palpation landmarks, bony landmarks. The top would be the sacral sulci, left and right. The bottom are the ILAs. Now this little cheat sheet kind of tells you if I have a backward sacral torsion, which are called left facing sacrum on a right oblique axis, or right facing sacrum on a left oblique axis. See how we drew the axes in? Helps you to picture it. Those are backward or posterior sacral torsions. Here's another key where they use different names for the same thing. If the sacrum is backward or posterior, would we say it's flexed or extended? It's extended. Why don't they just call it an extended sacrum and make it easy for all of us? But we'll call those backward or posterior sacrum. You will feel that the sacral sulcus moves closer to you. So if you bend your paper in such a way that that's moving closer to you, it tells you, okay, those edges are going to be prominent. So if you had a bilateral sacral extension or bilateral sacral torsion, bilateral posterior sacrum, all the same thing, those sacral sulcus on both sides will be prominent, sticking out. Conversely, what will be deep? Inferior lateral angles. Sacrum. So that's probably one of the easiest things to describe if you had a pure sacral extension. Pure sacral flexion, what's moving away from you? Bilateral sacral sulci. And what's moving towards you or becoming prominent to palpate? The ILAs. So you have flexion, extension of the sacrum. That's the easiest, and I know I'm going slow with this because there's somebody here who has not had an ability to picture that motion well. When I took my first muscle energy course, which was 4 days long to cover the same material, I had no clue of what happened the whole time. I went home, I was like, this is nuts. Because I didn't get the nomenclature. So obviously it took me a little while to get it, but eventually it worked once you get that down. So I want to just make sure that no one is lost here. Now in terms of which direction is the sacrum facing, we know that in the trunk, if the trunk faces to the right, it's right rotation. Okay. Trunk faces to the left, it's called left rotation. So we'll call it like thoracolumbar rotation, even though we know most of it is thorax. There's reciprocal rotations of the lumbar spine and the sacrum, just like there are reciprocal flexion extension movements. So if the sacrum turns to the left, if you follow on your sheet the two things that say left, left on right, and left on left, okay, those are your left-facing sacrums. So that's, you could kind of think of it as, well, if I imagine the sacrum rotated to the left or turned left, we would call it a left on a right axis or a left on a left axis. So do that with your paper. Okay, if my sacrum turns, patient's sacrum really, not mine, sacrum turns to the left, it's a left on right or a left on left. If the sacrum turns to the right, it's a right on left or a right on right. Now it doesn't do pure rotation like that. There's a side bending component and a rotation component together. So just like the other vertebrae, sacrum is basically a bunch of vertebrae fused into one. So for the ease of discussion today, we'll consider it one big chunk of vertebrae in a triangle shape. Side bending and rotation will always occur together in the sacrum. So if the sacrum is torsioned, let's take a look. Hold the top of your paper where it says left on right and the bottom where it says right on right. Now, and have it facing you. I'm pointing to you so you can see where I am, but have it facing you. So if mine's facing me, okay, if the sacrum's moving on a left axis, it moves this way. So tip your paper and just look to see what happens when it's moving on a left axis or a right axis. So let's stand up a minute. We'll do a little exercise. Get you moving. This exercise is modified from a Dr. Brandon Parker, who has a whole video of this kind of stuff online. You can Google that, and I'll bring that up for you later. So be the sacrum again. Be one with the sacrum. Here's your sulci. Your feet, if they were together, are going to be the apex of the sacrum. So let's do sacral flexion. Which way do you move? This is anterior. Sacral flexion. How about sacral extension? So as your anterior, the sacral sulci are deep and the ILAs are prominent. As it's posterior or extended, sacral sulci are prominent, ILAs are deep. Now, what happens if I turn left? Left rotation, technically. But rotation doesn't occur alone, it occurs with side bending. So if I'm looking forward to the left and down, that is a left-facing sacrum, okay? On which axis? Left axis. Okay, how about right on right? You're going forward to the right. What about a backwards sacral torsion? Right, backwards torsion. So you're looking back, you're extending off to the right. How about a left backwards torsion? So it just gives you an idea. On a left backwards torsion or posterior torsion, what bony landmark is going to be prominent? The left sacral sulcus. And what moved away? The right ILA. Okay, so does that help you picture a little bit more? Sometimes we're a little kinesthetic, we therapists and trainers. Okay, so it's good to have that kinesthetic feel. Because once we start talking about like which is which, I'm going to repeat, you may have a seat please. I'm going to repeat what we went over yesterday at the end of the day when you were in that coma, and we'll move on. So we're looking at muscle energy to correct somatic dysfunctions. I'm just going to scroll through these quick and we'll get up to that slide. Okay, now we're seeing there's 3 axes of rotation for the sacrum. So it's a triplanar joint, the sacroiliac joint. There's your 3 axes of motion. Okay. I gave you a cheat sheet that describes some of that sacral motion, like this little cheat sheet we created here. And it just helps you with your review. So in flexion, where does the sacral base move? Forward or anterior? Okay, where does the apex or the coccyx move? Posterior, so in other words, the tail sticks out. Okay, what's that direction called? You might have seen these terms, sacral nutation. So sacral flexion or forward motion of the sacral base is called nutation. More terminology for the same stuff we already knew about, right? Okay, and then the lumbar motion is reciprocal to that. As the sacrum flexes, the lumbar extends. So this is just interpreting the little cheat sheet. For those of you snoozing like you got it already, congratulations. For the rest of us, we might take a moment to appreciate it once again. Okay, so sacral motion extension, the base is moving posteriorly, so you are palpating those sacral sulci becoming more prominent. Okay, base is moving posteriorly. Where is the tailbone moving? It's like a scared animal. The tail is tucking under. Okay, that's called counter nutation. Counter nutation. And what is the reciprocal lumbar motion? Of course, flexion. We're going to use these reciprocal motions that when we see a sacrum is, say, locked in flexion, we're going to try to create what kind of lumbar motion goes with extension of the sacrum. Lumbar flexion. So we'll use lumbar flexion as a muscle energy technique to create and restore sacral extension. Does this make sense? It's like what we did yesterday. Gee, the body part won't flex, so let's try to get it to flex. We'll contract the extensors, and after they let go by that autogenic inhibition or post-isometric relaxation, now we can get a little more out of it, okay? So that's that. The test that we're going to use here, we discussed a whole bunch of tests yesterday, but what I see most cited in the literature as far as the sacral torsions and sacral somatic dysfunctions would be the seated flexion test. That's palpating the PSIS during full forward flexion when the patient's sitting. What muscles did we cancel out compared to the standing flexion test? Hamstrings. Now we don't have to worry about people having tight hamstrings. We're looking at true motion across, iliosacral, sacroiliac joint. Okay, and the spring test. Now in the literature, The spring test, we did that yesterday. We just pushed posteriorly, on the posterior aspect of the sacrum in an anteriorly directed force, like a PA glide, so to speak. And we did that right smack in the middle of the sacrum. So pain or limited motion there is an indicator of SI joint dysfunction. But we're going to divide this into those 4 quadrants that we talked about later in the day. Oh, push on the sacral sulcus left, push on the sacral sulcus right, push on the left ILA, push on the right ILA. So you're looking at the 4 quadrants. Which one is sticky? Which one doesn't have a nice little oscillatory motion to it? Feels like an abrupt stop to motion or just blocked. That would be a nice indicator for us, and those are some of the newer tests we see out in the literature, that 4-pole spring test that we called it. Those are very important for looking at assessing, is the SI joint locked or not in terms of the sacral motion. Okay, so what are the most critical landmarks? Again, just repeating to make sure you got it. We'll call these problem areas. Sometimes people call them red flags. Tom Oakler in his SI course calls them problem areas. In medicine, typically you think of red flags. What's a big red flag when a patient comes into your office and you're taking a history? What's something they tell you that you'd call a red flag? Pain is doing what to them at night? Waking them up at night. Or pain doesn't follow typical orthopedic testing, expectations for provocation tests. So that red flag, they lost a lot of weight, they look kind of green and emaciated. What's that a red flag for? Maybe cancer. Okay, so red flags. We're calling this problem areas or red flags that alert you we could have a sacral dysfunction. And the problem areas here, or red flags here, would be if you palpate, you're noticing and writing down which is the deeper sacral sulcus side and which is the inferior or prominent ILA. Because side bending and rotation occur together in the sacrum, if you palpate that ILA and it's prominent, it's also going to be inferior. So that tells you there's a bit of a lateral tilt or a side bending component in that sacrum, okay? So deeper sacral sulcus or inferior prominent ILA. Now you might palpate these important red flags of landmarks on the same side of the sacrum. If they're on the same side of the sacrum, that's more of a flexion or extension somatic dysfunction of the sacrum. If you're palpating these problem areas or red flags on opposite sides, okay, of the sacrum, right sacral sulcus, okay, is deep, left ILA is prominent. That's telling you, aha, sacral torsion, okay, right on right, left on left, that type of thing. So this kind of gives you your diagnosis in a single slide. And then you can decide, is it a right or a left? So try to get this in your head first. Keep that available for yourself. Okay, so clinical Pearl, same thing again, flexion extension dysfunctions are present if you find the target's red flags on the same side. If it's on the opposite side, that sacrum is torsioning, side bending and rotation together. Torsions are very, very common. It's most common for people to have forward sacral torsions. Dr. Sharon Weiselfish, I mentioned this book earlier. To be honest with you, I found it to be the most clearly written book on muscle energy, and I've read quite a few, mostly osteopathic. She's a physical therapist, NCS certified, and she's written the most concise. So again, I don't get any kickbacks for telling you this, but let me tell you, this got rid of my headache on some of this because many of these books actually are full of typos of right and left. So when trying to figure something out, and then I found out later, oh, it was meant to be a left, and I know I made that error with you yesterday. I apologize for that. But it's easy to mix them up. Very concise. Take a look at it later. She probably has new versions of it. I got this like really cheap used online. It's great. So she looks at it a little bit differently and definitely worth taking a peek. Okay? Torsion dysfunctions. She says that the torsion dysfunctions are most common. Probably 80–85% of the torsions are forward sacrums, flexed sacrums. And probably about 15% she feels are backward sacral torsions. Which one typically gives patients more trouble? The backward sacral torsion, because it takes the disc and compresses it. And now you have lots of things. And I've personally had these dysfunctions particularly, still have one I'm working on currently. The backward torsion is no fun whatsoever. And then you go to the doctor's office and they'll diagnose and tell you it's a herniated disc and you need a lumbar fusion. And you find out, well, if you just fix the posterior torsion, everything is fine. And I've seen this on patients over and over who were scheduled for surgery, You go and you do these corrections, obviously not just a backward sacral torsion correction, but a group of physical therapy techniques. And I've had surgery canceled on numbers of patients because you're approaching the dysfunction in the joint that's irritating the disc and irritating the nerve. So that's really worth looking at. Okay, clinical pearl. So bilateral flexed sacrum, both sacral sulci go deep. Bilateral extended sacrum, both sacral sulci are prominent. Another key, if it's flexed or extended sacrum, what will you find diagnostically on your provocation tests? Positive spring test for those extended or posterior sacrums. When you go and you spring, it's not moving because it's extended. You're trying to push on something that's already prominent. You're going to see a positive spring test, and it will typically hurt, and it will also be locked or hypomobile. So that positive spring tells you, oh, I better look for a posterior or backward sacrum, an extended sacrum. Maybe what I need to correct. We went over this page. I put a slide up here. I gave you the page. You don't have this slide. I gave you the page because ripping out of the book, I'd rather you have a big thing you could see. So everyone understand what this said? You're good? You could use that as a little tool. Especially if you go back to your clinics and you're trying to tell your coworker, well, this is what we did. You have a paper you can move around and show them. This is what I'm talking about. Okay, so again, know the terminology. Right on right or left on left, the letters are the same. That's an anterior or forward sacral torsion. It's a flexed sacrum. The letters are different. Right on left, left or right. It's a posterior or backward sacral torsion. It's an extended sacrum. That's a big trouble. How do you know? Positive spring test. More aggravating to the patient. Okay, and I gave you another cheat sheet with all these landmarks again, so I'm not going to bore you by reading it all over again. The only thing I added was that bilateral sacral flexion and extension, that occurs on a middle transverse axis of the sacrum. Let's look at the muscle energy techniques. So if you have a unilateral sacral extension, now, first I have to give you the little disclaimer that some physical therapists I've had discussions with, like, that's not possible. And other physical therapists, if I didn't fix that, the patient would never have walked again. You know, you get the other big drama of something. So whether this actually moves exactly like that, as I said, some of this is a little controversial. I try the testing, provocation tests like spring test. I try the palpation. If it looks like it might be that, I'm going to try the treatment. If it works and I see the patient has, better straight leg raise after, better gait, can transfer without, lurching over to one side and whatever functional test, that is what I'm interested in. So you decide on your own what the patient couldn't do before they came to you, and then you decide, well, what can they do now? And you could use all of your mobility tests and stuff that we discussed. Okay, so let's go back into where does the sacrum go? In a unilateral sacral extension, okay, this is in your slides there, so you don't necessarily have to copy it again, but the picture might be interesting. Unilateral sacral extension. So if it's extended, what landmark's going to be closer to you on palpation? What will be prominent? Top of the sacrum, the sulcus, right? It's extended. So it's posterior at the base. So you're going to see sacral sulcus is prominent and stuck. Which one? The left. Now I drew the sacrum here. It looks like it's tilted or a little side bent to the right because that's how the mechanics are working with this unilateral sacral extension. So you're palpating the sacrum, you find, prominent left sacral sulcus, deep right sacral sulcus. Here's like the middle of the sacrum. What do you want to do? Palpate the ILAs. The right ILA is prominent and inferior. They're opposites. Red flags are problem areas, so it's a torsion type thing. Opposites. But here, what do you find? This is confusing because some people say, well, if it's opposites, it's really a torsion. And some therapists will say, this doesn't really exist because if these two red flags are opposites, it's a torsion. Looks like a right sacral torsion. But what happens? If you have the person go into prone propping, or that sphinx position, lumbar spinal extension, you're going to find, on testing, the left sacroiliac joint is locked, and this gets even worse when they go into extension. So again, some of the motion testing people think is controversial, but if you go back to, and this is again my opinion just from doing it, go back to your spring test. I spring on the 4 quadrants here, which one didn't spring well based on what you see here? Which one is sticking out that's not going to spring too well? The right ILA. So I just add that in terms of if I tested the mobility, if the right ILA is prominent and I try to push it down, it's stuck locked backward. It's going to be positive or limited in pain. So the treatment for it, they call it muscle energy here, but it's actually very close to a mobilization technique, and sometimes these techniques overlap. What are we going to do? If it's prominent on the left, what do you do to reduce it? It's sticking out posteriorly. Where do you push it? Anteriorly. So instead of memorizing all this stuff, just think about, well, where is it? Where do I want it to go? So I'm going to put my hand here and I'm going to push it anterior. Now, if it's side bent to the right, so to speak, this ILA is superior, this ILA is inferior. Where do we want to push this ILA? Inferior. To try to put it back to where it belongs. So we're going to work with the patient's breathing, which is why they put it within the muscle energy category. We're going to push on the sacrum as they're breathing. Remember when we did the breathing with the down slip of the ischial tuberosity? And we were pushing on it, telling them to breathe, resisting, pushing on it, breathe out, resisting the breathing in. This is very much like that. We're using the muscle energy of the breathing and how that moves through the body. So let's get somebody on the table and let's go through like we did yesterday. Instead of like showing you and then you're bored watching, let's figure it out as we go. So get a patient on the table in prone. So ultimately, if you have a unilateral sacral extension, the SI joint is locked. So if you did your seated flexion test, if you did your spring test, what did you find? The left side is extended. Left SI joint is locked. Hypomobile. So that's what you're going, the patient might say the left SI joint hurts. Another patient might say the right SI joint hurts. So it does not necessarily always match. I find just personal experience, haven't seen it in literature, it usually does match the spot that's locked. But on another patient, especially if they're kind of flexible to begin with, sometimes that patient, the hypermobile side is what hurts because that's what's moving around doing all the work. So either way, I'm going to treat what I find regardless of where the pain is. You know, it's interesting, make a note of it, but look at the whole picture. So come in, palpate the sacrum. Now when I do that, you guys got a lot of gear. Okay. Where is the sacrum? Now she has thin clothing. I could palpate right through it. So I can see, okay, here's a little curve of the lumbar. Here's my iliac crests. Here's my windshield wipers. Okay, there's that PSIS. Are you sensitive at all in here? No. Okay. And on this too, with the palpation, women, you'll find they're farther apart. Usually men very much close together. So don't always expect them to be in the same place because women have a wider pelvis. Okay, so here's a PSIS, and I could just kind of get a sense, gee, like where are they in terms of their level? Here's the midline, come down from the PSIS, just a finger width or two, a little bit medial, superior. Feel for that soft space, sacral sulcus. Now I'm going to follow what it says up here in terms of what's prominent. Left sacral sulcus is prominent. Conveniently, hers actually is. So, guess you read the book before you got here. So left sacral sulcus is prominent, but let's go down and check those ILAs. I like to go down once I'm already here and just see where are the sacral prominences here, the spinous process, and then come lateral. Where's those ILAs? Now I'll pretend here because she doesn't actually have this dysfunction. But what do we have here? Which ILA is going to be prominent? The right. So problem areas on opposite sides, left sacral sulcus, deep, okay, right LA prominent, opposite sides. That would tell you it's a torsion. But here, what do we got? Unilateral extension on one side. Let's do a spring test. So if I come in, general spring test, just right smack in the middle of the sacrum. Any problem with that? Clunk. Okay, we got an adjustment out of that. There we go. Now, there's an interesting feature. What typically happens? Anyone familiar with quantum theory, quantum mechanics, and some of the new complementary medicine approaches? what they're saying, and this is shown in actually scientific literature, simply observing, not even touching, but simply observing the patient makes changes in their body. So, and this happens whether you're observing some molecules dancing around in a lab or whether you're observing a person. And I see this also because people's brains connect to their bodies, don't they? So when they know you're observing them, can't they make changes just based on your observing them? And I see that sometimes, like, well, gee, I thought it was crooked this way, but now it looks crooked that way. Well, she changed. When I did my spring test, she actually adjusted. I don't know what adjusted, but something made an audible pop here. Could you feel where that was?
It felt like low left.
Felt like low left. Well, I honestly didn't feel exactly where it was. It just felt like it went clunk. So perhaps that changed already. So just bear in mind that your provocative tests might have mobilized something and it wasn't the muscle energy at all. So if that happened, I might want to go back and see, well, what happened there? And actually, remember, we just said she had part of the dysfunction more symmetrical. So whatever was a little bit stuck with her just from the spring test. So if she was my real patient, would I have to move forward and do the rest of the correction? No, because, and here's where the chiropractors often have a good point. Sometimes manipulation alone did the thing. But will it hold if I don't address that long-term muscle contraction or the muscle inhibition or extra excitement of the muscle on the opposite side of the joint? So these are the things we're looking at. I want to see the whole picture. Does it make sense? This is kind of fun. Gee, thanks for doing that. I'm really glad you came in here. Okay. So let's pretend her, and I'm just going to exaggerate this. So left sacral sulcus prominent, right sacral sulcus deep. Okay. What else we got? As she comes into prone extension, gets worse. So come up and prop up on your elbows. Oh, it got worse. Let's just pretend. Got worse. Okay. And on the right ILA, that got worse too. More prominent, more inferior. Okay, so then she has a unilateral sacral extension on the left. Now, if she's sticking out on the left here and I push here, what's going to happen? And put her out of that sticking out position. Okay, so relax down for me. And here we use the breaths. What I've seen in literature is to do like 5 reps of 5 breaths where you're doing an anteriorly directed force over the top of the left side of the sacrum, so over that left sacral sulcus. So I'm not going to push hard because I don't want to create a dysfunction, but just kind of fake it here. So push in. Now take a deep breath. As she exhales, I'm going to put in my anteriorly directed force on the left upper quadrant of the sacrum, and she breathes in. And the same thing again, hand over hand. I will put the palm heel over that area. Sometimes, now I've had my wrist reconstructed a few times, so I actually don't do it this way. If you have bad wrists, you want to save your wrist and not have a bad wrist, find the same area. I can do it, and this is just my own personal opinion. I've never seen anyone else do it, but it works. I use my elbow, not the pointy, bony part, nice and flat, and I go through with my body weight. Can you feel that, how I can lean through there? And I could be very precise. Okay, with my proximal ulna, and this is a nice solid bone versus, do you want to keep hyperextending your wrist on people who have really tight areas? And it's just interesting, even back in PT school and people were complaining, oh, my wrists are hurting. They kept telling us, well, just keep going. Gee, we're our own worst enemy. So we do the anterior push for 5 reps. Now what? Which way is the sacrum tilted or side bent towards? The right. So if that right ILA is prominent and inferior, what are your choices here? I could push it, and this is different than what it says there, but I just think you're reasoning it out. If it's inferior, which way could I push it? Superior and anterior. Again, that's not what's in the book there, okay? But that's what works based on what you're seeing where the bone is. So I could do take a deep breath in. I'm on the right ILA, and as she breathes out, I'm pushing that anteriorly and superiorly. So where most of the muscle energy books addressed one plane of motion at a time, just push anteriorly for 5 breaths at the left sacral sulcus, and then they have you push inferiorly for 5 breaths at the left sacral sulcus. Look and see, where is the picture telling me the sacrum is? Where is my palpation telling me the sacrum is? And think about, how can I mobilize it and put it back? And if you're using the breathing with that mobilization, Slowly taking up the slack, breathe in. And as she breathes out, anteriorly directed force, left sacral sulcus. You're following it, so it's the muscle energy of the breathing that's working with this. And I'm actually doing more of a mobilization, aren't I? So this is a combination technique, and I find that with the mobilization perspective works better than sitting around, well, let me memorize that, this got deeper there, and this. Now, what did I feel in her sacrum? And that's what I told you earlier, and you asked, well, how do you actually sequence this? I go by feel. Where's the sacrum? Where's my spring? And there's a physical therapist who's an expert in this area, also Jerry Hesh, has some very good programs. I bought his whole home program, and really, really, really good stuff explaining this, working more from a spring test perspective, including the myofascial, including the mobilization. Okay, you want to go ahead and try that with your partner? Please be aware that we're practicing on each other. Don't really go and yank on your partner and push hard. You create a dysfunction, right? Okay, so be careful. If I'm okay, the left sacral sulcus was prominent, and I'm going to do my anteriorly directed force with my left palm heel on the left sacral sulcus. So as she breathes in, I let her breathe in, and as she exhales, I'm push, 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 push. Follow it to the end barrier. Remember, we're all dealing with barriers here. Muscle energy concept. I get to the barrier. As she breathes in again, I lock my hand and I resist her inhalation. Then as she exhales, I follow it anterior, anterior, anterior to the new barrier. Then I lock my hand still in that position and I wait for her to breathe in again. I resist the inhalation. And as she exhales, I go anteriorly again into the new barrier. Do you see how we're following barriers just like we did yesterday? That's a great question. What is the mechanism that I typically hear from patients that causes these sacral dysfunctions? And depending on the dysfunction, different mechanisms. I've seen very little in the literature alluding to what causes what dysfunction, but if you're thinking about something we're going to do, which is a bilaterally flexed sacrum, what is one time in someone's life that lasts, probably about 9 months if they're lucky, that they might have a bilateral sacral flexion where the sacrum tips forward and they're in that pelvic tilt anteriorly and something's very big in front of the body. Okay, so that's something I've seen in the literature. That the most common to see during the pregnancy, that bilateral, okay, both sacral sulci go deep, both ILAs are prominent, the sacrum is in flexion or anterior. So that's one thing that we hear all the time, and I see all the time. As far as the other sacral torsions or the imaginary unilateral sacral extension, some people feel that that's a possibility, others don't. There are many other axes of motion that have been discussed in the literature relative to the sacroiliac joint. And I'm calling them hypothetical axes because the jury is still out on exactly what are the definitive axes of motion of the sacrum. We know that you have the superior, middle, and inferior axis. That's mostly what you see, that flexion extension of the SI joint. That's obvious during postural changes. You see movement about those axes. We have that oblique axis we talked about, right oblique axis, left oblique axis. There's other axes that are being discussed in literature that I didn't address here because it's too confusing, and frankly right now it doesn't appear that any of us know what we're talking about, including me. So I'm leaving the hypothetical axes out, but I'm leaving the possibility that what's described in the literature, okay, what's in your book comes out of the literature. It's not my stuff. It's not the Schmidt technique. I didn't make it up. But I'm showing you the traditional, like Fred Mitchell originator style of muscle energy, and then I'm adding to it. We're going to add some myofascial components. We saw just here with this so-called unilateral sacral extension, we added some of that oscillatory mobilization component with the breathing being the muscle energy component, using the energy of respiration to alter the tension of connective tissue that's pulling this joint apparently into an abnormal position, the sacroiliac joint. If you really think about the mechanics in the axes that we described, this isn't possible. But because there's other axes being described in literature, and we can't say that we found them normal for everybody, because what's happening in the literature is that people have so many different shapes, so many varieties of sacroiliac joint shapes inside the joint itself, that different people have different axes of motion. So this is one of the reasons that I think the palpation isn't always reliable, And one of the reasons why I might find this type of a somatic dysfunction on one person's sacrum and get the same landmarks palpate on another person, but it doesn't seem to match my spring tests. And I think that has to do with this abnormality of different people have different shaped joints. Unlike the glenohumeral joint is pretty much shaped the same way on everybody. You learned your convex, concave rules and so on, but this is less predictable. So again, I'm just asking you, check and see, follow the landmarks that are shown in the literature here, follow the motion testing that's shown in the literature, and then, okay, that may be true, but let's go ahead and follow what's actually moving on the patient when we spring it. Let's follow that, because we could test that, we could treat it, we could see if it responds immediately by retesting. Does this make sense? And that's how I'm asking you to look at this. So when we talk about the unilateral sacral flexion next and so on, you're thinking, how does that move? Go by feel, which means you tested the mobility, you decided what's hypo, what's hyper, can you work on that hypomobility and see if you make a change. And of course, functional testing pre and post treatment to see, okay, it worked, great, something I want to do. Didn't work, chalk that one off, we're not doing that one again. That's all. So please keep it simple. This looks like I really have to try to figure it out, and it doesn't all make total sense. Ultimately, if you're finding these landmarks, okay, prominent left sacral sulcus, right ILA, okay, and it gets worse in prone prop, you want to push an anteriorly directed force and an inferiorly directed force on that left sacral sulcus. That's all this is describing. And see if pushing those forces during the breathing, so as they breathe out, you push anteriorly and or inferiorly. I usually combine it, frankly. It's a lot easier than doing each separately. Literature, everybody shows it separately. I don't know why. I do them together. Little functional tests you can do pre and post treatment that are so quick, and I find they work so well for my patients because they see a change like that. Before I treat them, I say, for most of these sacroiliac involved patients, they have trouble either lying flat or standing still. Now, I can't lay flat on my back. Oh, it starts to hurt. And you notice their back arches. You could drive a truck under it, you know. So what do you see? How long can you lay down before your back hurts? Oh, I don't know. Okay, lay there on the table perfectly flat. Don't move. I'm going to clock you. Tell me as soon as the pain starts, timing number one, and then tell me when the pain is unbearable that you must move. Number two. So I might have two timings. Pain, static supine tolerance, pain initiated right SI joint after 60 seconds. Intolerable, and pain was 5 out of 10 on a pain scale. And then after 2 minutes, pain was 10 out of 10 on a pain scale. Patient could no longer sustain the position. It's a functional test. Laying down is a function. You can't lay down, you're probably not going to sleep very well. How about standing? What's it like what's it like if you wait in a grocery line and it's a long line? Oh, I can't stand there for very long. My back goes out. What do? Oh, I lean on something. What are they telling you? I need some relief from my psoas, right? Doesn't this stretch more of the psoas and this will relax it? So something to think about. Just listen to what they tell you. Okay, I want you to stand. I have a little spot on the floor. Put your feet together. Stand on that spot and don't move. Tell me when your pain starts. And they're there, and 45 seconds later, oh, I could feel it starting. Okay, stay there as long as you can. And when you feel you can't anymore because the pain is intolerable, you must move. Let's clock that. And I find, a minute and 45 seconds later, I got to move. So I have something I could document immediately pre and post treatment for any of these interventions that we're talking about here. And people were asking, well, what do you do in the clinic? How easy is it to just ask them to stand there? And if I don't have time because I'm running late, I'll say, here, you clock yourself. Stand there. See how many seconds when the pain starts and how many seconds. If the patient has a brain, they could do their own clocking. And they could tell you, yeah, it was 45 seconds before I had to move, okay? I put that in my note, pre-treatment, post-treatment. Post-treatment, their stance tolerance was 1 minute and 40 seconds longer. Excellent. Post-treatment, their supine static lying tolerance, oh, that increased to 3 minutes. And I can put my pain scale from the numeric pain rating scale. So this is very quick functional testing that you could do pre and post-treatment the same day, the same visit, and sometimes right after doing your particular intervention, whatever it was. So I could show I made a change. We're going into the so-called left unilateral flex sacrum. Again, these unilaterals are controversial, so I'm showing you, here's what's out there in the literature. I recommend go by your testing, go by your feel on your mobility testing, on your spring testing, and take it from there. Because some people will say, well, I feel like it goes this way, and practice. Get 4 or 5 clinicians together, feel the same sacrum, all of you, and compare your notes. And feel the same landmarks and compare your notes and start to see, especially if you're working together with the same group of people, that you become reliable amongst yourselves in how you approach the palpation. Because again, the jury's out in terms of literature that we're not terribly reliable. We're not palpating the same way in many cases. So here, I'm going to check and see if you're palpating on a patient and you're finding the left sacral sulcus is deep, the left ILA is inferior or prominent. This is on the same side, so that means it's a flexion or extension problem. How do you know if it's flexed or extended and which side it is? Okay, you're going to ask them to go into their prone prop position. In prone prop, you're extending the lumbar spine. As the lumbar spine extends, what should the sacrum do? It should flex. So if it's normal, it will go ahead and flex, and both of these sacral sulci will get deeper symmetrically. What happens here? They do. They get deeper and symmetrical. So the happy place where they're stuck is in flexion because they're symmetrical in flexion. When you go in sacral flexion, lumbar extension, that's another way that we get confused. I have to make sure I tell you which is flexion. Sacral flexion, lumbar extension. So the left SI joint is locked, it's stuck forward, and you're going to find a positive seated flexion test. So when you check those SIs and they went forward, up the left SI is moving as one. The ilium and sacrum are moving, they're locked together. So you see that move first and more superiorly. Positive seated flexion test. Okay, so left SI joint, you notice that one. Left ILA, inferior and prominent. What do you want to do? Well, if this is inferior and prominent, you want to push it where? If it's prominent, moving posteriorly, you want to push it anterior. If it's inferior, you want to push it where? Superior. So I'm correcting what I'm palpating, what I'm feeling, and what's not springing as well on patients. So let's go ahead and get your partner in prone. Let's pretend that the partner has this. You're palpating in neutral. So get in there, palpate. Oh, we got those PSIS here. Let's come in and see what's going on there. Okay, let's pretend that left sacral sulcus is deep. Wow, that's really deep. The right sacral sulcus is very prominent. So that's not supposed to be symmetrical. Now as you go down to the ILAs, palpate, where's the bony prominence there? I like to palpate right down the middle of the sacrum. I find it's more comfortable for patients, a little less invasive. Where's the ILAs? Oh look, left ILA is what? Inferior and prominent. So I'm just going to exaggerate on here. Inferior and prominent. Oh, we have target areas or problem areas, red flags, both on the same side, so we got a flexion extension issue. I wonder if they're flexed or extended. Let's see what happens when he goes into prone propping. If he extends his lumbar spine, the sacrum should flex and both sacral sulci should go deep because the base moves anteriorly during sacral flexion or back lumbar extension. Oh, look, it's symmetrical. I wonder what happened to the ILAs. Come back and see there. Oh, look, they're symmetrical too. So in flexion, he moves fine. It's his happy place. What doesn't he do? Go back down flat. Neutral. Oh, that right sacral sulcus is prominent, left sacral sulcus is deep. What's happening? Unilateral sacral flexion, happy place on the left. The left side of the sacrum failed to go back into relative extension in neutral. Okay, so what do we want to do? Okay, left ILA is inferior and prominent. We want to push it superior and anterior. So I could put either, some people, if you have a small person, you even use your thumb, but I think that's too much. Most people do the palm heel, hand over hand on the left ILA, and you're going to start pushing it superiorly for 5 breaths, meet the barrier, resist the motion of the sacrum on the inhalation. Okay, so superiorly and anteriorly. I combine them Some people do them separately. So if you combine them, I'm going to push that ILA superior and anterior. Now with your partner, don't go yanking on them and create a dysfunction. Just pretend you're doing that, okay? So breathe in big. Follow the breathing. Good. As he exhales, I'm taking up the slack, moving superior and anterior. As he inhales, I lock it in and I resist the motion. As he exhales, I'm going to follow the motion to the new barrier and hold that. Inhaling, I'm locking it in, I'm still. He exhales, I'm following it to the new barrier. It's 3 to 5 reps, and then check again. Does he have a positive seated flexion test on the left? Does he have symmetrical landmarks or not? Are they still asymmetrical? Now, if they're still asymmetrical, would I go and do the same thing all over again? No, I'll probably go back, try some myofascial techniques, or try something else. You know, hey, if something's not working, try something else, okay? No sense in beating your head against the wall if that didn't open the door, okay? Try something. I might do some myofascial stuff. I might do some mobs. Gee, I wonder what the spring was like if I did some spring testing on all 4 quadrants of the sacrum. Maybe I should have worked a little more with the mobilization. Maybe I wasn't pushing with enough pressure to really taking up the barrier. And that's something especially new practitioners doing these techniques will often miss, approaching that barrier and taking up all the slack. And that's really a myofascial perspective, like taking up the slack into the barrier. So make sure you do that and follow through, and that takes some practice. So go ahead and try that left unilateral flex sacrum. Meredith and Shannon have a fabulous little piece of artwork here. So here's a concept of putting your anatomy book on your copy machine. Cut out the sacrum. Here's a superior axis, right oblique axis, left oblique axis. What happened to the left oblique axis? Oh, there we go.
It works better without bendy straws.
It works better without bendy straws. So there's something else. Be aware too, there's a middle and inferior axis. So if you want to add 2 more straws to really screw us up, you could go ahead and do that, but that's awesome.
Yeah.
Left oblique axis, right oblique axis, flexion, extension of the sacrum. That's just awesome.
Yeah?
Wow. I love it. Bilateral, this should be easy, relatively. Bilateral sacral flexion. Okay, I'm looking at take your paper out, but you're looking at the paper here because that's the sacrum you're looking at on the patient. I'm looking at the patient's sacrum, and if they have a bilateral flexed sacrum, they're deep in their sacral sulci on both sides, and they're prominent in their ILAs on both sides. Well, gee, that sounds logical. It moves on a regular transverse axis, regular axis, and who do you see this on? Pregnant people. Okay, how about people who just have really tight hip flexors? Some of the people who have that flexor synergy with the internal rotation pattern in their legs, maybe after a stroke or a head injury. I see it frequently on those people. So this is pretty easy. Let's go ahead and try it. On this, the spring test is going to be negative because they're flexed, they're springing just fine. Very good flexion. Very good extension motion, poor flexion because they're already at the end of the range. So let's get a body on the table, let's palpate. One thing to mention on all of these sacral corrections, it works better if you have the patient's hip on the same side you're treating abducted about 20 or 30 degrees. I've seen some sites say 20 degrees, some sites say 30. If the legs are slightly abducted, it tends to open up that sacroiliac joint, makes it a little easier to move. So I test them in neutral, but then treating, you might want the hips abducted a little bit, like 20 degrees or so, not a huge thing. One of the key issues I see on patients who have pelvic or sacral somatic dysfunctions, they often stand with their hips abducted because they want to be, right? You've seen that. They want to be in that comfy position for the sacrum. So that's a little key. It doesn't mean they have one, it's just another feature that you could look for. So let's take a look and let's pretend that Joe has had a pregnancy for 9 months and now he's famous and he has delivered a bouncing baby boy. How's that sound, Joe? Terrible. Terrible. Okay, so we're Joe is not in a good mood now. He didn't want the baby boy after all. Okay, so palpating, there's your PSISs. Now what do we have here? We have an elastic band restriction. Those just get in the way. If you want to mess up your palpation, leave the elastic band in the way. So on patients, either I'll tell them pull it up or pull it down a little bit. So here, can we pull this up a little bit?
Sure.
Just get it out of the way. Beautiful. Now I have a thin piece of clothing I could work through, no problem. There's those PSISs. There's the sulcus. What do we have here? Oh, let's pretend. Both sacral sulci are deep. Let's come down from the spinous processes. Let's find that, oh, both ILAs are prominent. Again, if you're just checking this for the first time and you haven't felt it on like 30 people or whatever, you're not going to know what normal is. You have to feel it on a lot of people. But both are prominent, so what do we want to do? Sacrum is flexed. We want to bring it back toward extension. So where could I put my hand? Palm heel right between those prominent ILAs. So palm heel, or I showed you earlier too, I often use my forearm. Make sure I find the spot with my thumb because the forearm is not as tactile sensitive as your hand. But you really save your wrist and hand. So I'll use my forearm, and now as he breathes in, I notice the motion. Good. As he breathes out, I'm going to go where? Anteriorly directed force on the bottom part of the sacrum between those ILAs. Okay. Take up the slack. Big breaths. Good. Breathing out, I'm taking up the slack. As he breathes in, I lock it in and hold it. Don't let it move. As he breathes out, I'm taking up the slack again. Most people teach, the hand over hand using the palm heel. So follow the breathing. You're right between the ILAs for 5 breaths, and it's anterior and superior. Okay, give that a shot. Good luck with the baby, Joe. If they're stuck in extension and the patient goes into a prone prop position, which would require sacral flexion, what's going to happen? It's not going to flex. So they might have pain or limited lumbar extension, okay, or lumbar flexion. Which one? Sacrum stuck in extension. It's happy there, which means it doesn't flex. When the sacrum flexes, the lumbar automatically extends. So when the patient does their backward bending, it will typically hurt. That's what I see on these people. I haven't seen that in the literature, but that's what I see on the people. The backward sacral torsions or extensions, whether unilateral, bilateral, or torsion, I see on patients, a presentation, it tends to hurt more, and it tends to be much more limiting. And again, back to Dr. Weiselfish, he says it's more or less like less than about 15% of the patients are having that backward type of torsion. So let's go ahead and look here. Palpate, PSIS, come to the middle, go up maybe a finger with where's the sacral sulcus. Oh, it's really sticking out on both sides. So very prominent sacral sulcus on both sides. Palpate, come down the spinous processes. What's happening with the ILAs? Oh, wow, they're really deep. I have to really get in there to get to them. So sacral extension bilaterally. I did my spring test. The patient was miserable and it was very stuck. Bilateral sacral extension. So where do we want to put our hands? The ILAs are anterior and superior. So we want to push it where? Inferior. So I'm going to get my hand right through between sacral sulci, inferiorly directed force. Okay, and then if you go down, depending where your hand is, if you're between the sacral sulci, I just do a straight inferiorly directed force, almost like an inferior glide of the sacrum. Patients love this. It's a giant release. The minute you put your hand on them, start that inferior glide, and as he breathes in, so big breaths now. He breathes in, follow the motion to the barrier, hold it. As he breathes out, inferior glide. As he breathes in, you lock it in. Don't let the sacrum start creeping back up. Breathe out, follow the motion. So same thing for 5 breaths. Okay, very simple. Go ahead and try that. That's a simple one. Gives patients immediate relief as soon as I start that little inferior motion. Like, they're extended back there. Okay, so if they have a forward sacral torsion, Okay, if it's forward, first of all, what does that tell you the sacrum is on that side? If forward is flex or anterior. So forward, why don't they just call it a flexed sacrum and be done with it? So forward torsion, right on right. If I'm taking out my little paper here and I'm looking to see what part of the sacrum, left or right sacral sulcus, left or right ILA, is going to be prominent on my palpation. Right on right is where on the paper? Down here. So what do we have? Right on right sticking out at you. Okay. Where's the axis of motion? Right axis of motion, right facing sacrum. So what this tells you by name, it's a right facing sacrum moving on a right oblique axis. If it's facing to the right, it's going to be going forward or moving anteriorly. So go ahead and check out that motion. What do you see? What becomes prominent? The right ILA on your paper. Does everyone see that? What becomes deep? Left sacral sulcus. So a right on right, if you tip your paper on that right axis, the right ILA becomes prominent, the left sacral sulcus, okay, becomes deep. There's our target areas or red flags. They're on opposite sides, so it's a torsion. If they were on the same side, it would be a flexion or extension dysfunction. What do? That's prone, neutral. Now we put them in prone prop. Everything turns equal. Everything's symmetrical. Very happy because they're flexed. They're forward. So when you put them in the sacral flexed position by extending the lumbar spine, sacrum automatically flexes. They're happy there. So what do you see? Just take a look at the picture here on your palpation. If this is a sacrum, here's your right oblique axis. Remember, the axis is named from the sacral base, the top of the sacrum. So it's moving, you're palpating. Oh, that left sacral sulcus is really deep. That right ILA sticking right out at me, they're very prominent, okay? And the sacrum is facing right, turning right on a right oblique axis, okay? So what's happening? Side bending and rotation occur together, okay? In the sacrum, it's just like the lumbar vertebrae. Side bending and rotation occur together. If they occur together, this is stuck side bent to the right. If the sacrum is side bent to the right by reciprocal mechanics, which way is the lumbar spine? Relatively. That. Side bent to the left. So if you want to correct a sacrum that's stuck side bent to the right, essentially, we're oversimplifying this so you could picture the correction. Okay? It's stuck side bent to the right, which means the lumbar is stuck side bent to the left. What do you want to do to the lumbars to fix it? You want to side bend the lumbars to the right to create left side bending in the sacrum. That makes sense? Everything's reciprocal. So we're going to think, okay, I'm going to put the patient now, just like we did with the lumbars, you can put the patient on any side, but I'm following what's traditionally out there in the literature and what's easy for you to do. You're going to put the patient on the right side, the side of the axis, and we want to create left, okay, side bending in the sacrum. To create left side bending in the sacrum, we have to create right side bending in the lumbar spine. So we're going to use those feet again, the side lying, lifting up the patient's feet to see can we side bend them. And what will happen naturally with that is a correction of rotation because side bending and rotation occur together as reciprocal motions. And let's go. Let's go ahead and try it. So let's get somebody on the table. Okay, so you're palpating. Let me just talk you through it again. And the picture is on the board as well as, description. That's all in your book there. So you're palpating. Here's your PSIS. There's my sacral sulcus. Oh, look at that. Left sacral sulcus is deep. Right is very prominent. Okay, and on the opposite side, if I come down in the ILAs, what do we find here? The right ILA is prominent. Now, come up into extension. Lean on your elbows. Arch your back. Good. Oh, look, everything turns symmetrical. Okay, so we have a torsion. To correct this, it's a right axis. We're going to put him on his right side with the axis that he's rotating on down. Just makes it easier to do the correction. So go on your right side. We're basically going to put him into right rotation and right side bending of the lumbar spine to create left rotation and left side bending of the sacrum. Okay, so remember, we're always doing a reciprocal motion. Let's palpate and see. So I'm going to palpate. We have to start again from the same position we're in. Here's the sacral sulcus. Here's L5S1. I want to feel when that L5S1 moves to see. Palpate again. And we're looking for the barrier as you flex up his legs. So you want the knees to have locked up against my body so I can move his knees and still have a hand available to lift and move his feet. Okay? So flex up until you feel motion. Right there, L5S1. Okay, good. That's my first barrier, flexion extension. Now, we want to achieve some right rotation. How could I rotate him to the right? He's laying on his right side. Put your right arm back behind you and turn your chest toward the table. Put your right arm behind you and turn your chest to the table. He can do that. Some therapists start moving the patient and lifting him. You're going to kill your back and your hands. Let him do it. Okay, so how much of the barrier? Now I can adjust the barrier. I might move you back a little bit. Good, no, stay there. Stay there. Just let me move you. And see, do I get anything? I got to go a little bit more. Up, right there. I felt the motion at that L5S1 when I rotated him quite a bit. Because remember, most rotation is in the thoracic spine. We're going to try to get it all the way down to the lumbar. The last lumbar, L5. So I had to rotate him quite a bit here. A way to do that, if we're not getting enough rotation, would be I could scoot. I'm going to just slide your body to the edge a little. I could scoot him a little closer to the edge. Reach your hand toward the floor. You see how that would give him a little more right rotation? He can help me. It's muscle energy. Let him use his muscles. Okay, good. You can relax there. Not quite so much. Good. So now we have our flexion barrier. We have our rotation barrier. Didn't side bending occur naturally with rotation? Okay, so and they occur to the same side with the mechanics of the sacrum. So now I have that locked in. Good, I have my barriers. How are we going to get that side bending? With the feet. Drop the feet off the table. Now, just play with feeling the motion. We're not treating it, we're just feeling the motion. As you're palpating, say L5S1, and just there, sacral sulcus, as you pick up the feet, you're side bending him where? To the left, passively. As you drop the feet, you're side bending him where? To the right. Now we want to side bend him to the right at the lumbars to make the sacrum side bend left to correct the right on right forward torsion. Okay? So bring him down to the barrier as far down as the feet go. Okay, there's the barrier. Push your feet up to the ceiling. Okay, so resist, relax, the left side bending, relax. Go more into right side bending. New barrier. Contract, hold it, 5 seconds, 10 seconds, whatever you feel is necessary for that patient. Relax. Take up the slack at the next barrier. Some people will also adjust the barriers, reach a little more to the floor for the rotation. I might even flex them a little more if I need to, so I could address the barriers in all three planes. But to be honest with you, I see most of it addressed just by working from the legs to get the side bending. Push your feet up to the ceiling. Okay, that will give him working the muscles to bring the correction about using his muscle energy. Relax. Okay, if I have him push down to the floor, what muscles is he contracting? The opposite. So just if you're thinking about what if he wants to do a self-correction? Let's just play with it. What muscles will he contract to do a self-correction? We want him to right side bend. Instead of me pushing your feet to the floor, you help me. You and me push the feet to the floor together. You see how he could assist? It doesn't have to be just post-isometric relaxation. He could actually assist moving in the direction you want him to go. Reach to the floor with your hand. Good. Reach to the floor with your feet. Let me help you. Let me help you. Oh, look how much easier we move through the barrier. And relax. So that's more of an assist, patient-assisted. Do you see what I did there? First we did the contract, relax, post-isometric relaxation, working barrier into barrier to stretch him in the direction he wasn't moving well. Then I could ask the patient, help me move into that direction you weren't moving well by adding his active contraction. So it's just another version. That's reciprocal inhibition, isn't it? So 2 ways you can work. I just want you to see that that's a possibility. Okay, let's go ahead and try that. Thank you very much. Be aware that you could treat the patient lying on either side. Just make sure you're putting him into lumbar rotation right, lumbar side bending right. So if this patient couldn't lay on her right side, I could have put her on her left side. Just move the legs in the other direction. Just create the motions. Don't worry about the direction that they're on the right or on the left. Guys, let me just mention, for a patient who can't lay on the right side, or it's just not convenient for you to do that because for some reason you were doing stuff, she could go on her left side. You basically want to create right lumbar rotation and right lumbar side bending to cause left lumbar, you cause that correction of the left sacral. So go ahead, pick up the feet. As she picks up the feet, she's getting right side bending. As the patient leans her shoulder back, she's getting right rotation. So here she could just have the patient push and pull with her feet. It's going to work whether she pulls up or pushes down. Okay, you're either going to use the reciprocal inhibition or the autogenic inhibition, the post-isometric relaxation. Perfectly fine. Good job. Okay, now we're going to do the backward torsions or posterior sacral torsions, which are really something stuck in extension on one side. So take out your little paper and let's take a look and identify the right on left backward sacral torsion. So just go by your paper right now. What you're looking for is on the screen. There's a lot of detail because a lot of things to look at here. So right on left, if you look at the top right corner, it says R on L. Let's just get the terminology down again because a couple people had issues with the terminology, and just some of us, we take a moment to really absorb all that. R on L means if that part of this paper is prominent, okay, so pull, face the paper to you, grab the top right corner of the paper, pull that towards your eye. So if the, what is that? That's the right sacral sulcus. If the right sacral sulcus is prominent, okay, closer to you, okay, what else? What goes deeper? Okay, the left ILA goes deeper, which means the right ILA is more prominent, okay? That's the right on left backward sacral torsion. It's moving on a left axis, but it's moving backwards. So if it's that little dance you talked about, right on left, backward sacral torsion goes back this way. Sacrum's looking like so. So it's a right-facing sacrum, facing my right, but it's extended back on a left axis. If it helps you more to stand up and feel that motion, go ahead and feel that with your body. So what do you find? Do your palpation. What are your target areas? Which sacral sulcus is deep? The left. Which ILA is prominent and inferior? The right. They're on opposite sides, left, right. It's a torsion. Positive spring test. If it's a positive spring test, typically that's found to be painful with the backwards torsions or extended sacrums. Just tends to be more painful, just more compression. Okay. On prone propping, the left sacral sulcus goes even deeper. Okay. Why? If they prone prop, the sacrum flexes. It flexes just fine on that side. So the right side fails to go deep as it should. Okay, and the right side is stuck, being prominent, it's stuck in extension. So this is where typically I see on patients that right SI is hurting, it's stuck, it's locked up. So what do you want to do? You want to bring them in the opposite direction. Here's a person who is stuck flexed and side bent left, so I put a different color. Your treatment's going to be to extend them and side bend them to the right in the lumbars. Now typically in the literature they tell you to put the person laying on the side of the axis upon which the sacrum is moving. As we saw from last time, you could lay them on any side. It doesn't have to be the side of the axis upon which they're moving. You have your target areas, okay, red flags on opposite sides. Left sacral sulcus is deep, right ILA is prominent. Problem areas are target, red flags on opposite sides, that's a torsion. Okay, go up into prone propping. Lean on your elbows, okay? Oh wow, look, it's deeper. Got worse, okay? So what happened? The right side of the sacral sulcus, the right SI joint, failed to flex. Okay? It's stuck in extension. That's why it's a posterior sacrum. It's stuck in extension. Okay, go back down. If I did my spring test, ow, oh, that's painful, and it may also be positive for locking, limited motion. So now, ow. That's a good one. Okay, so lay on the left side. You want to extend them, side bend them right, rotate them right. So how can I extend her? Well, let's try that first. We could use the bottom leg to extend her at the lumbar spine. As the lumbar spine extends, sacrum flexes. That should help with the correction. So you okay laying on the side like this? So I'm going to keep that right leg flexed up. Put that left leg down a little, just a little bit. I'll start her in neutral just to make positioning easy for me. Scoot a little my way. Good. Palpate. 4, 5. L5S1. What do we have there? Find the palpation and then see if you could extend them. So go ahead, try extending them until that L5S1 stops moving. Good. So right here. You okay with that? Mm-hmm. What else you got? Side bend right. You're trying to side bend the sacrum to the left. So you're going to side bend her lumbars to the right. How do you do that? You could rotate her right for one thing, and you could use the leg as a lever. Okay? So to side bend her to the right, if I lift up the leg, knee okay? Mm-hmm. Won't that start to create some side bending to the right? Now as I'm lifting, nothing's moving. When I get to here, I felt some movement. So I got my side bending right. Now with your arm, reach your right arm back behind you toward the table. Good. Come forward just a little bit more. You can just rest your arm. That's good. Back just a touch. Good. Right there. There's the barrier. So she can help me. And now I'm going to finally, with the leg, what am I going to do for the leg? She's at her barrier of right side bending to create that left side bending, post-isometric relaxation. Push your foot down to the floor. Lightly. Just lightly. You know, you don't have to have them going like gangbusters. I tell them, give me a pound. Relax. Take up the slack. We got a lot of slack out of that one. Feel the difference? There's the new barrier. Okay, push the foot to the floor again. Relax. As we side bend the lumbar to the right, we're side bending the sacrum and rotating the sacrum to the left to correct this dysfunction. Okay, push again. Good. And relax. Take up the slack again. You could also have her, go a little bit more into right rotation. Oh, just lean back a little more. There's my barrier. If I put something under her leg, like my leg, if I wanted to get a little more extension, I could go ahead and do that as well. So you could go ahead and use all 3 planes of motion and fine-tune it. But I find working from the leg and the side bending helps the most. And it's a lot easier on the patient. Okay? Great. Thank you. Going back to what Sharon Weiselfish is talking about, she says that most people, like 85% of the people, will have a left-facing sacrum when we're looking at these dysfunctions. And what happens if you have, think about a pelvic tilt. Anterior innominate on the right, relatively posterior innominate on the left. I see this in about 80-something% of people. Which way did the sacrum go based on how you saw my pelvis work? Left. So you also see that with that left sacrum. And check to see, is it a forward torsion, a backward torsion, what's happening. So very, very common to see that. And just stand up for a minute. I just want you to picture there's something in your pelvis that has to do with gait. Separate course, really looking at the gait. But I talk to my patients, in their language so they can understand. And we're talking about their hips. And as you're walking, there's reciprocal motion of the hips. There's relative rotation of the ilia. Okay, inflare and outflare of the ilia. There's no upslips or downslips when you're naturally walking. But for patient, I tell them, you have headlights. I point to the hip joint. So right below that ASIS, think about your hip joint as your headlights. When you're walking, which way do your headlights go? If you heel strike with your right leg, so go ahead, heel strike with your right leg. Which way did your sacrum face? To the left. And then reciprocally, heel strike with your left. Which way did the sacrum face? To the right. So think about that when you're assessing someone for their gait. Do they have problems at heel strike on one leg, or is it more of a problem at push off of the other leg? Which way is their sacrum facing? If they're telling you, it hurts to walk. Well, does it hurt more when you hit with your right heel or your left heel? Like, where in your walking cycle do you feel the pain? That might point you to, gee, I wonder if it's more of a sacral torsion. And maybe I should look for that if the patient's having pain with gait. So you see how even on the interview you might detect something that will cause you to go looking for this type of a problem. And one of the things I find helpful, again, this is not part of the course, but in terms of stabilization exercises, you want to give patients things to do at home to hopefully maintain the correction or even self-correct. And with that, some of the things I refer people to, I find people are much more likely to sit and have a relaxation. Yeah. People are much more likely to participate in something if they have someone to do it with and they make it kind of fun. So patients I find who are poorly compliant with home programs but are very social animals, so to speak, I'll say, find out where your local continuing education to local high schools or colleges are. They probably have courses in yoga, courses in Pilates. They might have courses in Tai Chi. So look those up. They're usually very inexpensive. They're a lot cheaper than coming to me. I'll start you with some exercise programs here, give you some like do's and don'ts, or be careful about such and such a movement, and then you could go into that exercise program. And I've done Tai Chi, I've done some yoga. I'm not a yoga expert, but there are selective techniques there that may be helpful to follow through. So let them go into some of those courses. The spinal stabilization is very good. There's whole exercise programs and courses on that. And then one of the most well-known names in that arena would be Beverly Biondi. There's a lot of spinal stabilization work and publications on it as well. But just think about something as simple as the transversus muscle. That's our corset muscle, holds our belly in, the deepest of our abdominals. How do we contract it? I tell a patient, put your fingers on your belly, suck your belly in a little bit, make believe you're pulling your belly button back toward your spine. Okay? Get a little tightening of the transversus. If you're thinking of this is a postural muscle. Postural muscles don't use really strong contractions. They don't use a lot of effort. They just contract for a long time. They have great endurance. So I'll tell someone, just contract a bit. They don't have to really suck it in, because now you're talking about more of a phasic muscle function. That's not the function. So I might tell them, give me 10% of sucking that in. Give me 20% of sucking that in. Give me 20% of your effort. And that matches what's typically found on EMGs as for a postural muscle, you want to use below 30% of effort to recruit that muscle, shown on EMGs. So I'll tell them, give me 20% of your effort, give me 15%, see if you can hold that. And I'll have them maintain that transversus contraction as they're going through a series of exercises. Now, we're not going to cover all the exercises at all. I just put in a couple of my favorites that are also represented in the literature when you're dealing with people who have perhaps some instability of one SI joint and hypomobility of the other. Typically, you have one and the other. So I may mobilize the one that's stuck, and of course I want to stabilize the one that's moving too much with some body awareness. Going along those lines, things like Feldenkrais, postural awareness through movement, any type of body awareness. Tai Chi is very good with that, to give someone a neutral position of their spine while they're doing movements of their arms and legs, and to be aware of that neutral position. Because if they have disc damage, if they have instability in lumbars, and they come out of that neutral, that's typically where they start telling you about their pain, or something's clicking, and oh, that hurt. So some of these stabilization exercises. I'd like you just to pop on the table with your partner, and as I talk you through the exercise, I'll put them on the board, go through. Most of these you may know, some of these you may not know how we modify it. So go ahead, get a body on the table. A pelvic bridge. Everybody knows a bridge. You're laying on your back. Lift up your buttocks. Most people do it sloppy. They just hike up their butt. They start arching their back. What about the belly? Before they do the pelvic bridge, have them bring the transversus in. So just rest here a minute. Put your fingers on your belly, because I want them to feel the muscle activation. Do their own biofeedback with their fingers. Now imagine you're bringing your belly button back toward your spine, so you're almost like sucking it in, making yourself a little skinnier, okay? Give me like 20% of that effort. You don't have to bring it in all the way. Bring it in maybe 20%. And then hold that. Just get them used to feeling. Feel that on yourself to activate the transversus. That's your corset muscle. Hold your guts in. We spend years going to school and sitting at desks and letting our abdominals get weak, and people wonder why there's so many anterior pelvic tilts. And too much lumbar lordosis with weight bearing on the facet joints instead of weight bearing on the intervertebral discs and the lumbar vertebral bodies where we're supposed to be. And we call that degenerative joint disease, and then we say, oh, that's from aging. That's not from aging. That's from repetitively doing something where you're weight bearing on the wrong joint surfaces. Facet joints are not built for weight bearing. Intervertebral discs and lumbar vertebrae are built for weight bearing. You go into that anterior pelvic tilt, that weight line starts to go posterior. Weight line is supposed to go through, from a sagittal perspective, right through your L4 vertebral body. If there's an anterior pelvic tilt, extra lumbar lordosis, that weight line, if you drop the plumb line from the ceiling, your gravity line falls posterior right through the facets. Now you're getting wear and tear on those facets. Now if you have any of those torsion dysfunctions, side bending rotation dysfunctions, now you're uneven on the facets as well as having too much weight on them. So aggravating. I've still read some studies. I just read some Medline updates last week. And in some of this literature that I showed you, I put up on the front table about SI joint mechanics and so on. Some people are still saying, well, just because someone is crooked in their posture or asymmetrical in their posture doesn't mean that's a problem. Well, maybe they haven't read some of the current literature. There's now finally coming up with literature that's shown over time positive correlations between postural asymmetry and movement dysfunction. And a lot of this is coming out of University of Madrid and also out of Brazil. Interesting researcher, if you want to write this guy's name down, he has tremendous research going on and is very well represented for high quality literature. Fernandez de las Peñas. And he's a lead researcher in a whole bunch of different studies on the correlations between posture, asymmetry, and everything from headaches to movement dysfunctions to functional problems with moving to pain. So something definitely worth looking at. We are seeing these new researches come up. So have them activate the transversus, get a sense of where is their pelvis in neutral, where do they have a lumbar lordosis. I have patients go through the little pelvic clock, press down, imagine there's a clock on your back, push down at 12 o'clock, and I'll press it with my finger, push down your pelvis now at 6 o'clock, feel that, try 3 o'clock, feel that on the right. Now push down more on the left, 9 o'clock, and I have them eventually go through all the numbers on the clock to feel that pelvic clock, to move in different directions. And people who have these sacral dysfunctions, they have a lot of trouble moving in specific quadrants. So that's worth looking at to see. Can you identify which quadrant is difficult for a patient to do on the pelvic clock? Oh, it's hard to get to 10:30. Okay, I want you to focus on that. And look and see, gee, what dysfunction? Haven't yet correlated those, but it would be interesting in a study to correlate, gee, what sacral dysfunction makes it difficult for him to do a posterior pelvic tilt to the right side, or go down towards 10:30 on an imaginary clock with his back. Okay, so keep that tuck in the transversus, that you're sucking in about 20%. Keep that tuck as you slowly lift your pelvis off the table. So it's all the awareness with it. Do it along with us so you feel it too. And I don't let them come up any higher. If they lose that transversus contraction, don't come up any higher. Let's just work on that. I'll see how many reps they could do efficiently with perfect form in the clinic. That's how many reps they're doing at home. Next visit, gee, I wonder if you could do a few more reps before you lose it. And over time, you progress and see what they can do. But as you see in the picture, I give them one of those big Velcro straps. See, well, this may be long enough. Now, many times patients will be doing the bridge and they'll find, oh, I'm getting all crampy in my thighs. The hamstrings go into spasm because they're trying so hard to keep their feet on the table. The feet are slipping. And if they're on these slippery tables, I have them do it on a mat, like a nice, either a carpeted floor or AirX mat with their shoes on so they're grippy. But if they're having a problem with the hamstring, do it again. Give me 20% of tightening up those abs, sucking it in maybe, okay, and then start lifting up the pelvis, keeping this nice and tucked. Now, at the same time, push your feet against this towel that I have wrapped around your legs. So if he's extending his quads against the sheet, he's apparently reciprocally inhibiting some of the hamstrings. I find that's very helpful for patients because then that hamstring spasm goes away. And I can tell you also, I've read some literature, again, newer literature, that says reciprocal inhibition doesn't exist either. Well, then how has it worked so well for over 60 years in the other literature? So it's just a curiosity. There's so much information out there. So any feel on the difference of the bridge with the strap or without?
Yeah.
What feels different?
More in the quads, less hams.
We're in
Also
the
a little bit less in the glutes.
We're in the quads, less in the hams, a little less in the glutes that he feels. So this is something might be a little easier. Patients who have sacral iliac joint problems that are significantly painful, I find they're not able to do this right away. I'll just have them doing the pelvic clocks and the transversus. Once they get that transversus to kick in, I find then, okay, get the hip flexors to calm down. Now they could kick in their glutes. They do a much better bridge. And I'll just have them do the part of the range that's comfortable for them. Okay, so let's bring up the next one. Now I don't have all this equipment here, but you're all familiar with working on a therapeutic ball. I do a lot of these exercises with spinal stabilization on the therapy ball. Again, try to have his pelvis in neutral. For this, I'm guiding him as he does, single arm lift, single leg lift, and then alternating right arm lift, left leg lift, while keeping the spine in neutral. And I'll palpate the spine as he's going through the exercise. If I feel him come out of neutral, oh, don't lift your legs so high, you're arching your back. Oh yeah, my SI started to hurt. Yeah, don't lift so high. Let's see if we could loosen up your hip flexors a little more first. So just other things. There's a whole bunch of stuff you could do using a ball. Even on the ball, I use some of that for some of my muscle energy techniques. Lumbars or thoracics, I'll have someone sitting on the ball, do their rotations, do their side bendings, flexion extension on the ball. Very easy for me on the floor. So this is called pelvic rotator cuff, and this is with a pillow. Some of you have pillows under the tables. If not, put your pocketbook or your partner's hand can be used for this. So have someone on the table. Don't just stand and watch. Feel it. And I'm saying to feel it because, sometimes as therapists we're know-it-alls. Oh, I know that exercise. If you've ever been hurt and you think like I have, oh, I know that exercise. My physical therapist says, you're not contracting your transversus. You're not even doing the pelvic tilt in the right direction. I've been doing pelvic tilts for 30 years in the wrong direction. Can you feel it right on yourself if you're all asymmetrical and crooked? No. So you've got to have somebody there with you. Don't assume, oh yeah, I know it because I've been doing it. You've been doing it wrong all this time. Okay? So I could easily show it on someone else and then I didn't have a clue of what I was doing on me. And it took my physical therapist to say, no, no, no. Okay? So with this pillow between the knees, this is basically an ab and adductor exercise. Having the knees flexed usually keeps the back out of that excess lordosis, so bend your knees. And I like to have something comfortable between the knees like a big fat pillow. And here we just have a sheet in the class, but in the clinic a nice big pillow. Some patients use a basketball. Now squeeze the knees together. Do your isometrics, hold it for 10. So getting those adductors, especially if you have those rotations, iliac rotations, anterior or posterior innominates. It's very nice to help stabilize after your muscle energy correction. Now I could also have them take a strap, so we'll just take a strap, wrap it around the top of the legs. Now you can use that to resist, make a knot in it. You could use that to resist abduction. So keep that transversus contracting. Don't forget the transversus for all of these. That's acting. Now pull your legs apart and hold it while you keep that contraction. Then you'd have the pillow between, so 10 seconds for each one. See how many reps they could do with excellent form. I might give them, oh, you could do 6 reps with excellent form. You're going to do 3 sets of 6 at home, little rest in between. Next week, oh, you could do 9 reps with excellent form. Okay, you're going to do 3 sets of 9. I usually work to fatigue on a patient. It starts to look sloppy, I'm getting off that exercise. If they can't do it right, what's the point of them doing it wrong? You compensate. Okay, so that's your pelvic rotator cuff, abductor and adductor resistance. Now you can progress with this with the bridge, with the stabilization, and you could use this with or without the belt around the lower legs. Presumably as they get stronger they don't need the belt around the lower legs. So add the stabilization, transversus, contract belly, do a nice bridge for me. So say he's gotten to the point he's good at the bridge. You okay with that? Can you slowly lift one leg off the table straight and keep your balance here? Don't let your back. Patients, the pelvis drops on one side, so I keep my hand there. How are you doing with that? Oh, you're getting shaky. Okay, let it go. Try the other side. And you'll see there's a considerable difference side to side on patients. So don't let that pelvis drop. Okay, good. If he could rest. If he could only hold it for 3 seconds, it's 3 seconds today. Maybe next week it's 5 seconds. And you work your way up that you see good balance, good stable core on here. So leg lifting during bridge. How about bicycling or leg raising during a bridge? Bicycling, very easy. It's also, I use this as a warm-up for patients before I have them do a lot of their back stretches to get some blood flow in the legs and the back. So let's get that transversus contracting. Bring your legs up in the air. Make believe there's a little bicycle here. Give me a little bicycle. And I don't have them lift too high, right? Or just see what level is comfortable for them the first time. But feel with your fingers on your transversus. You need to check to make sure your abs are kicking in, because if they stop kicking in, you stop the exercise. Maybe the first day you could do it for 30 seconds. Maybe next week you could do it for 90 seconds. You work your way up, okay? So bicycling. How about some eccentric lengthening of the psoas muscle? How many people have that anterior pelvic tilt? Especially if it's more on one side, you might want to do more reps on that side. Can you do some eccentric lengthening of the psoas to start to stretch? How about get that transversus activated? Let's do the right leg. So slowly lift up the right leg, have it straight, and then from the straight position, you're going to lower the straight leg down as slow as you can without losing the contraction in the belly. That's difficult. Usually when they start to get down about here, oh, lost it. The leg falls, the back arches, the butt sticks out. So you're looking for those kinds of things. Okay? Feel the other leg. So contract the transversus, straight leg, and a slow eccentric lowering. Of course, your rectus femoris, iliacus, psoas. These are all active there. How's that feel for you? And relax. Most people will find the mid-range is easy to do. When they get down toward extension, oh, the SI joint just clicked. Oh, my back popped off the table. And I'm going to monitor that on the patient. More ball exercises, if they're limited in flexion, I have them do some flexion stretching on the ball. If you found they were side bent, a lot of these muscle energy techniques were addressing side bending issues where, you had a whole bunch of transverse processes prominent on one side, they're side bent to the opposite side. What are you finding? Why not do some stretching over a ball? Now, for my little 87-year-old lady with bad balance, this is probably not a good idea. But for people who could tolerate it, I'll start with them, and for each of these patients, I'm with them, guarding them until they're able to manage, independently working on the ball without fear of falling. I make sure that they're stable. I don't give anybody ball home programs without making sure they have good balance on it. And of course, you let them know, don't do it near furniture. Oh, I'm doing it in my living room and I have a glass table with a sharp edge. Well, stay away from that. What people have in their homes, if you've ever done home care, so clear the area. Or put pillows against those other things, so if you do bump into them, a pillow will shock absorb for you, that kind of thing. The other thing on the ball, if they're not as stable on the ball, I'll put little wedges, towel rolls, or pillows under each edge of the ball. So the ball is actually more stable on the pillows, where they'll get a little bit of challenge, but not so much that things become dangerous for them. Myofascial release. This is a wonderful complement to everything we've done here with the muscle energy. It is not a muscle energy technique itself, but based on my clinical experience, I find the muscle energy alone doesn't work very effectively for patients who have chronic problems where there's connective tissue tightness, fibrosis, which we might identify as fascial restriction or sometimes called myofascial restriction. I do this as full seminars where we get into all the background of the pathomechanics of fascial physiology, when it becomes pathological, what are the changes in the body. Instead of getting into all that here, I just want to show you some of the techniques and guide you through. In a nutshell, fascia or connective tissue is what surrounds and compartmentalizes everything in the body from the macroscopic right down to the cellular level. So anything in the body is surrounded in fascia, whether you're talking about the bones, the coverings of the muscles, the epimysium, the endomysium, the perimysium, right? Globally, right down to the cellular level. Coverings of the nerves, the neural lemmas, coverings of everything in the body, every organ. So if that connective tissue, fascia, becomes short or restricted, fibrotic, scarred down, it could impair movement. So when we're looking at things like, oh, where are the mobility tests that we did with the muscle energy limited? Where did it show that there is a hypomobility? That's an area that typically I will find fascial restriction. So bones don't just move themselves out of position. Either an outside force comes and puts that bone in that position, like a trauma, a slip and fall, an accident, or an inside, an intrinsic force brings the bone into that position of side bending, rotation, and flexion, however you found it. and that could be the muscle attachments to the bone. So I invite you, go back and review and research some of what you have learned eons ago when you went to school. Look fresh at that anatomy again. Look at those muscle attachments. Look at the directions of the fiber orientation of the muscle, and that gives you a good indicator of where that muscle tension is going to pull those joints out of their neutral symmetrical positions. And also gives you a good concept of where can I place my hands on the body to interact with this connective tissue network and facilitate a change that gets the body moving into more functional movement patterns. Essentially, from the myofascial release perspective, it's just a fancy word for stretching. That's all it is. We stretch tissue over a period of time, maintaining the pressure, sustaining the stretch over time until the practitioner appreciates the release of tension in the tissue, which often feels under your hands, or sometimes you use the forearms, the elbows, but we'll start with the hands. It's easier to sense. It feels like the tissue's melting down, softening. Some people describe it as feels like butter melting or jello melting under the hands. Often there's a vasodilation effect related to that. So during the myofascial or soft tissue work, you may notice, oh, the tissue feels like it's warming up. Oh, look, there's an erythema response on the patient. Sometimes it's such an obvious vasodilation as that connective tissue releases, blood flows into the area, and you feel what's called the therapeutic pulse. Gee, as I was doing that release, I felt almost like a pulse under my hands, the vasodilation. That sympathetic nervous system releasing some of what we called yesterday, that segmental facilitated reflex that caused the vasoconstriction. So very nice for increasing circulation, very nice for increasing mobility. Back to the basics, get your goniometer and measure the mobility before and after. Use your mobility and flexibility test to see, did I make a change? But your fingers say a lot as well. So if you found on the patient who had any of these lumbosacral pelvic issues, you said, wow, that patient had trigger points. Typically associated with those trigger points, those hypersensitive areas that when you push on them, people do what? They jump, right? They twitch, they yell. You can measure that, so more stuff to put in your notes. How many notes do we have to write today, right? Lots. Pain scale, the trigger point. Oh, it's a 7 out of 10 on the pain scale. Okay, did they twitch or jump? Positive twitch sign, positive jump sign. How about, oh, okay, did I palpate in the muscles those taut bands of fibers? Feels like guitar strings in the muscle. When you flick them with your fingers, it's often like plucking a string of a guitar. So we put in the note, positive taut bands, right upper trapezius. Oh, positive taut bands, right piriformis, wherever you feel. Very commonly we feel this in the psoas. In the erectors, how many times you feel like you got those guitar strings going up and down the erectors? And you could go and isolate what they are. So we're going to take a look at that and see, can we engage our hands, and I'll show you directions, I'll show you typical releases we would do for a lumbosacral spine and pelvis, and we'll give it that a shot. Okay, we're going to be focusing on lumbosacral area. So if you found some positive spring tests, if you found that lumbar flexion, we'll just use a pretend example. Say lumbar flexion is limited, just gross range of motion, and say you found in here, oh wow, that whole right side feels pretty relaxed. The left side, and we're just pretending here, taut fibers, very tight bands. When I roll my fingers over them, she twitches or maybe she jumps. Oh, that really is sore. And when I come out to that left quadratus lumborum, wow, that's really sore. It's telling me, okay, let's check and see how the mobility is. Perhaps she's limited in right lateral flexion on gross range of motion. So you know, what's tight limiting right lateral flexion? Stuff on the left. What's the stuff on the left? The erector, spinalis. They're in 3 layers, right? Spinalis, like cords, longissimus, iliocostalis, going up from the spinous processes and transverse processes below to levels above. And of course, quadratus lumborum coming from the lower ribs to the iliac crest, transverse process of L4 and L5 to the iliac crest. That's a real problem because of the connections to the iliac crest and L4, L5. So you see a lot of the rotations you may find, flexion, rotation, side bending dysfunctions of the lower lumbars. You need to check out that QL, that quadratus lumborum. How about for an upslip? You think that might be something important? What if she had an upslip on that side? I might think I have to do some myofascial to those erectors on that left side, that QL on that left side. So is it okay with you if I roll this up? Yep. Now, I could show you hand position through the clothes, but to work on a patient, to get a grip on the tissue, you need to have your hands on the tissue. If you're working through clothes, it's very hard to push through sweaters. You pull on their clothes. It's just difficult to do. So I'm going to roll this up a little bit. Now here she probably doesn't want to expose everything here, so we'll just pretend we took that down there. Identify, you know where the PSISs are. Okay, your sacrum. I like to have one hand on the sacrum. And check and see, what is the mobility like if I glide the tissue proximal to the sacrum superiorly? So if I go lightly on the skin, what's it like on the left side? What's it like at the middle? I'm just going to roll that a little bit more so you can see my hand. Is that okay? Yep. So say I'm stabilizing the sacrum, what's it like to glide up at the midline? So superior glide, gliding up on the right, gliding up on the left. Let's just say, oh, say it was more restricted. I didn't have as much superior glide on the left. If I'm using light pressure, I'm accessing what tissue? Skin. If I go a little bit deeper, now we have what tissues next? Lumbodorsal fascia. Then if I go even deeper with my pressure, now I'm into the erector muscles. So depending upon the force I'm using, I'm going to access skin, then lumbodorsal fascia, then erectors, etc. So remember, the tissues are always in layers in the body. The amount of pressure I use that I detect the restriction is the amount of pressure I use to treat the restriction. So light pressure, oh, her skin moves pretty well, but as I go deeper, not a lot of motion there. So I'm just going to take up the slack to the barrier, hold it, and here I can either just stabilize the sacrum and mobilize from my upper hand, or more commonly I try to see, I think, around an imaginary clock. For my lower hand, if I do a little counterforce pushing straight inferior or inferior left, inferior right, at which angle do I feel the best stretch for her, the biggest restriction? Oh, say it's right there. I could hold it. So taking up the slack and holding it and waiting until I feel it gliding, softening, releasing. So here, even if I push harder, nothing's really moving at that layer, so I might as well wait. Most of these fascial releases take about 1.5 minutes to 2 minutes. Some will release a little quicker, some might take a little bit longer. But I'm holding and waiting for that softening, and I won't be holding here on my volunteers because you'll all be sleeping waiting for that to happen. But say then you felt some glide, maybe a little bit subtle, take up the slack at the new barrier, hold again. So I'll typically do 2 or 3 releases in a given area for whatever body part I'm working on, and then reassess how is her forward flexion, how is her right lateral flexion. Oh, did that affect my FRS on the left? You know, check and see to do your motion testing at the end. So it's also one of those things that I just call it a quickie shotgun technique for the sacrum. If the sacrum's stuck and I just get that sacrum is right under the whole palm of my hand, full contact, a very slight intention of inferior glide, opposite hand, very slight superior glide, and just start with that, and then as you ease in a little deeper, a little deeper, a little deeper, till I feel restriction right there. I'm going to hold that. How does that feel for you in terms of the pressure and your sensitivity?
Good.
Comfy?
Yeah.
Okay, so positive editorials. That's good. This usually feels really good on patients. And hold it and hold it. It often feels to the practitioner like the sacrum is actually gliding right down off L5. And considering how much we sit, how much we stand, and how compressed we are here at that L5-S1 interspace, it's a really nice release. So that would be what we call lumbosacral decompression. Some people describe it as inferior glide of the sacrum, this myofascial release to lumbosacral junction. I could then compare, instead of going so directly on the sacrum, I could go from the ilium to the ribs. Gee, how are the lumbar muscles? Lighter pressure lumbodorsal fascia on the left, a little deeper. How are those muscles? Lumbodorsal fascia on the right, how are those muscles? And crossing my hands is just easier for me as a practitioner. Couldn't I do the same thing like this? But it's a lot harder. It's easier this way. Don't hyperextend. Have your hands, wrists more neutral. Some people like to use the forearms. I can do the same thing with my forearms, midline, left side, right side. And I'm thinking in terms of where I'm putting my hands, origin insertions of muscles. Those erectors, QL, ribs, upper spinous processes, upper transverse processes to the iliac crest. Gee, is she tighter from here, or here, or here? Well, I felt it more tight right here, so that's the handhold I'm going to use. But did you see how I tested? Where's the tension? Oh, right at that angle, and hold. So let's go ahead and try a little prone, some of that lumbosacral decompression, and compare the erectors, the obliques on each side. Thank you.
Thank you.
Now you'll notice that you don't really need lotion for this, but if your hands are really slippery and dry, or the patient's slippery and dry, you could use a tiny touch of lotion. There is lotion in the restroom. But you just want the tiniest touch to make your palm tacky and grippy, so you get a purchase on the tissue. If you use too much oil or lotion, you're just going to slip, slide away. What is the lightest pressure you could use and still achieve a stretch? How about approaching it from that perspective? Think about having your patient close to you, close to the edge of the table, so you're not straining. If you need a step stool, use one. Some of you have step stools there. Please resist the urge to drill your palms into the patient. This is about how light can you be, how low can you go, how light can you be, and feel the restriction, feel the tension, compare side to side. If you have sometimes two therapists might want to work on one patient at a time. Somebody could do the right side, someone could do the left side. If you're thinking about your hand placement, think like one hand maybe on the origin of a muscle group, one hand on the insertion, and get a longitudinal stretch through the muscle. Make your hands flat on the body. See the fingers sticking up? You're going to get tendinitis. Full contact, a relaxed hand. Good. So, and if you're slipping, just moisten your palm a little bit to make it sticky or grippy. Otherwise, you have to push harder to not lose your grip. So a tiny, you know how you lick your finger to turn a page of a book? You'll lick your finger, treat the patient? No, only kidding. But you can moisten with a little bit touch of lotion. Hand sanitizer even. Good. Hold it until you feel the relaxation, you feel the lengthening occur. It feels like your hands start sliding apart, but they don't slide on the skin. They take the skin and the underlying tissue with it. Okay, so if you're slipping on the skin, you're just massaging. You're not doing fascial release. So classic sense on the part of the therapist, it feels like your hands are moving as the release happens, the lengthening happens. Doesn't look like much. Gee, I felt like everything softened. I felt like my hands moved farther apart, but I didn't see them move like 2 inches. You might see them slight, but you find the difference in the mobility after doing 2 or 3 releases. You could measure it with a goniometer. You could measure it with your mobility tests. Many times when you first start this work, everybody has their fingers up in the air off the body and they're pushing through the palm heel. Get your whole hand in contact with the body. You'll have a better grip, you won't slip so easily, and you won't give yourself tendinitis. I like to start this work with, what if I just rested my hands on the body and used just enough pressure to move the skin? It doesn't take much pressure without sliding my hand across the skin. Then I could go deeper in layers. So imagine there's a clock face on the body. It just gives you a perspective. Superior 12 o'clock, inferior 6 o'clock, lateral 9 o'clock, lateral 3 o'clock, and all the other clock times around it. So does her skin move up 12 o'clock and down, 12 and 6, 3 and 9? How about 10 and 4? How about 2 and 8? Which direction felt sticky? We're just pretending now here. Yeah. Oh, it felt sticky going that way. So I want to put my hands across the direction where I felt that restriction. Gee, is it tighter here? Right side, left side versus midline. Now a little deeper pressure. Midline, right side, left side. You access different layers of tissue. And then I could go all around a clock. Oblique angles, especially with sacral torsions. Yep. Okay, lumbar, flexion rotations. Great. So we're going to do myofascial release, but this version of the myofascial, I'll put this on the board for you in just a moment, is called muscle play. People have different words for things, but these are things I've seen out there in the literature. I've seen other people use. Nomenclature, again, is an issue in the connective tissue world. One person calls it deep tissue massage, someone else calls it Rolfing, someone else calls it fascial mobilization, another person calls it myofascial release. What the heck are we talking about? We're working actually now through the Fascia Congress to get a standardized nomenclature. So we met with people from 38 countries in March to go over this and pose this as a question, and hopefully this group of scientists will get together and come up with standardized terminology for everything we're doing. So for this today we're using muscle play. What is muscle play? It's basically stretching a muscle at a right angle to its fibers. So in other words, it's a transverse stretch across the muscle. Everybody learned friction massage, right? It's a transverse stretch, but you're rubbing on a muscle tendon back and forth, usually pretty vigorously. And that's myofascial work as well. That's Cyriax transverse friction massage. Another name for connective tissue work. This one has a transverse approach as well, but we're not frictioning. We're taking up the slack and holding until the tissue melts down and releases. So say you're back here, this is a lumbar pelvic course, so we're going to look at the lumbar spine. And any problems? No. Palpate, if you're coming in, you did your exam, you found out there's some restrictions here, maybe in side bending. If you're working on the extensors, there may be some restrictions in flexion. It might be one-sided, two-sided, you decide in your eval. But here I'm going to palpate into the muscles. We know those erectors are vertically oriented fibers in terms of their orientation. If I palpate from the midline, of course, you have your spinous processes. The first band of muscle you'll feel is the spinalis. Very deep and thinner. Remember, these are encased in a very thick fascial sheath. Then, oh, that's a little tighter there. Feel the difference? Yeah, okay. Longissimus, next layer. And then iliocostalis coming out to the ribs, not as tight. And in a real patient, I check the whole spine, by the way. I don't just look here at the back because the back hurts. I check the whole kinetic chain. But I'm going to be more precise in that area that I found where I localized some restriction. So, okay, that longissimus on the right, I could feel the taut fibers. It twitches underneath my fingers and actually more thoracic even for him. See the difference? Now let's compare, in the interest of brevity, we're just looking here at the lumbar. What's happening here? Oh, we have a little band action here as well. So you can play the band. See that twitching under my fingers? Is it sore at all or just tight?
A little bit sore.
A little bit sore too. So I might ask him, where I found this really tight from 0 to 10, when I pushed on here, how bad did it hurt? Give me a number.
3.
3. So in my note, okay, I could decide, where am I? There's L4, 3, you could count up. Which number is this? Say this was T8, left T8 transverse process pain scale, a 3 out of 10 on palpation. I have something to put in my note. Maybe right lateral flexion is limited. Maybe forward flexion is limited. Maybe it's also related to his lats coming down across here. Maybe his elevation of his shoulder is limited. So these are all things I look at for that area. So where does the taut band begin? Where does it end? Comes down a little deeper here. So these muscles, connect into sacrum and iliac crest, so I could do my cross hand stretch that I was just showing you. Where the tension starts to where the tension ends. I could have done that using my forearms. That's a longitudinal stretch, you see, when we did the cross hand. Here we want to do a transverse stretch. Can I do a transverse stretch of the whole muscle? I don't have enough hands. So I'm going to pick part of that muscle. Can I get my palm heel right at the border of that tight guitar string? Do a little medial glide. And we're always describing the direction that we're moving, medial glide, pushing medially. Feel a little stretch when I do that? Breathe into that if you can. So say I worked on that, I waited for that to release, I come up to the next level. Where's that taut band? There it is. So I do some medial glide to that part. I picked the most tight part of that area to work first. Breathe into, how's that one? That's a little tighter right here. And hold. And I rested my fingers in between. Now, pushing through the palm heel all the time can often be very fatiguing for your wrists, so you might want to use your forearm. This is a nice long band, so I could use the edge of my ulna there, do a nice medial glide, feel a little stretch when I come across. So that's all one direction. What if I wanted to do a lateral glide? Approach the lateral aspect of that muscle band. Now I'm just kind of scooped towards me with my forearm. And I try to be precise about where I line up my arm, right next to that band. Find it with your fingertips. Line up. Oh, there we go. Feel it now? And hold. How is that pressure for you? So just enough pressure that I can feel the restriction. So I meet and I match the resistance I feel in the tissue. You find the barrier. And then hold until that softens. Another way I could have done this, I could do a lateral glide stretch by working across the body. So I'm not going to walk around because I'll block the camera, but here, if I found that taut band in the right longissimus, I could take my palm heel from the medial side of the band and do a lateral glide, muscle play stretch. I could have tested first, gee, how bouncy is the barrier here versus here versus here? Oh, this one's not so bouncy. You'll feel the difference? The whole body wants to bounce, but I'm not getting much nice oscillation or elasticity at the end of the range of motion there, so that's where I'm going to focus. Lateral glide muscle play. So really more lower thoracic for him. What if I wanted to do it as my forearm? Okay, sometimes you have a small area. I could just use thumb over thumb and work from the thumb. Some people use fingertips. So whatever lets you take that band and give it a lateral glide muscle play, you're at a transverse or right angle to the muscle. So let's try the muscle play. Thank you so much. So question is, if you're in the middle of release, keep going. Just be able to see the board. Someone was inquiring, like, what do you do to document this? And this is, I do the same thing, whether it's muscle energy, therapeutic exercise, myofascial release, joint mobilization, whatever I'm doing. I have grids that I have typed up as like a Word document in my computer, and I have different grids for my favorite things to treat or things I treat most commonly. So if I am having a treatment for myofascial release, the billing code for that is 97140. So if an insurance adjuster in all their lack of wisdom is reading this, at least they'll recognize something on the page because they understand the money. So I have 97140, the billing code for myofascial release, and it says myofascial release at the top. I just abbreviated here so you could see. You could make your own grids in your office, and you can even use it in the computer that someone could do a checklist of what they treated and pre and post treatment. So I have the name of the patient, their diagnosis, any precautions, because each time I see it or if a therapist is covering for me for my patients, I want to make sure that precaution or any type of special red flag is on there for the patient, their doctor's name so we know who to refer to. 97140, the technique, the billing code. So then I'm going to list the various techniques here, and I just chose to list 3 because we're doing 3 here today. And then date. So each time they come in, I might have like 6 dates across the same sheet of paper. And say today I decided to do, I did a cross hand stretch to the right quadratus lumborum, the right QL, that was limited. You know, elsewhere in my note I have the exam that shows limitation. So pre-treatment, I might put in, and again, I don't have room here on the board, but it would say pre-treatment, say left side bending, 0 to 20. Post-treatment, left side bending might have been 0 to 30 in terms of my range of motion. Pre-treatment, the pain scale in the right QL might have been an 8 out of 10, and post-treatment in the pain scale might have gone down to a 3 out of 10 for the trigger point in the QL. So do you see how I could go ahead and document easily? Let's go ahead and do a myofascial release leg pull. Now, the myofascial release leg pull is basically a giant circumduction motion with stretching. And for fun, I didn't put this in your book, but I'm going to add the muscle energy / PNF stuff that I typically combine with it. Basically, you're going to do circumduction of an extremity. I don't care if it's an arm, a leg, either way. There's an arm pull in myofascial, there's a leg pull. We're going to distract the joints of lower extremity gradually, starting from, ankle, knee, hip. As I distract, the pull is going to go through from distal to proximal, releasing the ankle, releasing the knee, releasing the hip, ultimately up into the SI joint, the back, etc. So depending on how much pull and where I can focus on getting maybe the whole lower extremity by holding from the foot and ankle. Or say there was some ankle instability, I don't want to pull on that, she has an ankle sprain. I can pull from femur and tibia. Would it be okay if I rolled this up a little, get a little grip? Shorts makes it easier, and of course loose comfortable clothing. So if I wanted to leave the ankle out of the stretch, of course I could simply hold proximally. If it was such a problem that I can't work on that knee right now, she can't have a stretch there, I could of course then just hold proximally on the femur. So you decide where you want to start your leg pull. I'll show you if we're doing the entire extremity. A circumduction, as you know, is if you take that extremity and move it through a whole circle of its available ranges of motion. This is obviously an arm as an example. The extremes of that range are what we often call our PNF diagonals, proprioceptive neuromuscular facilitation. Remember that Knott and Voss stuff? You have these diagonal patterns of motion that bring the proximal joint of the extremity through all the various ranges of motion. So an example here would be we're aiming to bring her leg from a position of extension, adduction, internal rotation to end up in a position of flexion, abduction, external rotation, and presumably go through all the ranges available of the proximal joint. In this case, the proximal joint is the hip, the lower extremity. I'm going to do that by going through a circumduction. So we could start from neutral, or some people will actually start from more extended, adducted, internally rotated. I find it's easy to start from here. So grip just above the ankle, down at the foot. What are some of the most common areas of tension? Gastroc, of course, soleus, Achilles tendon. So I want to make sure I add that dorsiflexion. If anything is uncomfortable, of course, you let me know, right? Anything I should know about?
Nope.
Okay. Check with your partner like, oh yeah, I just had an ACL reconstruction last week. Should you be yanking on that? No, probably not. Okay, so just things that are needing to be healed, of course, let that go first. I'm going to apply some traction. So first I'm going to distract from the foot and ankle. Distract, 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 distract. Feel how the pull starts going up your leg? You should feel that pulling. And as I start pulling your leg, I'm going to make a giant circle. You're going to feel pulling up the back of the leg, going up to the inside of the leg. It should be a comfortable pull. Sometimes stretching is slightly uncomfortable, but it should never be sharp or painful, like more than a 5 out of 10 on a pain scale, say. So this is how I talk to a patient. I tell them what to expect. We're going to give a big motion of your leg like this, like I'm doing with my arm. I'm going to try to stretch in different areas. I'm going to see, can I identify, which if I did an exam, I would already have an idea, of what part of the range of motion will she be restricted. Pretend on the exam I found that her abduction was restricted. Again, we're just pretending here. She's obviously a healthy specimen. So say it was restricted here, I'd come out here. It felt like from here to here, smooth, 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 smooth. I'll see what she actually has. A little change right there. You feel that? Mm-hmm. So it was smooth, no other body parts moved, if you're watching carefully, until I hit here. When I hit here, when I started stretching the inner adductors, hamstrings, her pelvis start to move. Feel it? Mm-hmm. Okay. In a patient, if I wanted to make a strong stretch, I might actually strap the pelvis down to stabilize it. Here, I'm just going to meet the barrier. I'm not going to exceed the barrier. See how I exceeded it? The rest of the body's moving. So right to that point of the barrier, feel how it changes right here? I'm going to give a little more traction, comfy. And now I'll hold, just like we were holding the other myofascial releases. We were waiting. Whatever time it took for that to release, it might be 90 seconds, might be a couple minutes. So I'll wait, that starts to soften. I'm doing this faster than I would with a patient. I go to the next barrier. Oh, there's a new barrier. I'm waiting for that to soften. The softening feeling from therapist perspective feels like the leg's getting longer, feels like it's getting heavier, feels just softening. Say I waited for that to release, I'm coming up and up. So wherever I feel a barrier, say this is smooth here, and a new barrier here, take up the slack and hold, and wait for that barrier. Again, I'm going faster than I would with a patient. I could spend 20 minutes on a really good leg stretch for a leg pull circumduction. I may do part of the arc of motion this visit today because I have X minutes. Next visit she comes in, maybe I'm going to do the next part of the arc of motion where I start to come. Now here the hamstrings start to get involved. So I'm going to back off a little bit, traction. Sometimes I'll even hug the leg this way to get a little bit more purchase on the leg. Feel the difference? Mm-hmm. Comfortable? And if you want to add that post-isometric relaxation, you're going to think triplanar. What 3 directions is she in a barrier? So coming up into knee extension, hip flexion, abduction, and I could just see, gee, is it more of a barrier with external rotation? So I'm going to line up those 3 barriers. You're going to push your leg like you're rolling your foot in toward that foot. When I say go, go. Hold it lightly, just a pound. 1,000, 2,000. So say you held that for 5 seconds, relax. So I could combine the myofascial and the PNF muscle energy. Go to the new barrier, okay, roll your leg in, bring this leg toward that leg, go. So I'm resisting extension, adduction, internal rotation, relax. Moving into flexion, abduction, external rotation. With traction, and so on. And I'd be working from here, and from here, and from here, and gradually I walk around the table. What if you didn't have that big a reach to walk around the table? Could you hold that leg for me a minute? I'll be right back. Now walk around the table. Now here I'm going to be in the way, so let me move that. So some people think, oh, I can't let the leg go in the middle of all this. Yes, you can. Do whatever you want. You're the therapist. You decide. You're the chief. Just make sure it makes sense. Now imagine as I'm starting to cross the body, if she's tight in her hip, what's going to roll? Spinal rotation, pelvis and spine. But if I keep my hand on the ASIS on the left, which you can't see because it's kind of buried under her pants, but I have that ASIS plastered down the left side. You okay with that? Now I could start adducting. There's my barrier, feel? IT band, iliotibial band, okay? Coming down from tensor fascia lata anteriorly, and the gluteus maximus, the biggest, strongest muscle in the body, posteriorly, coming down like a Y, going into that tensor fascia lata, iliotibial band. That comes down into the lateral tibial plateau. So she's going to get a stretch all the way up through here, feel? Plaster down that ASIS, stabilize it. If not, she's just going to roll up. Feel the difference? You lost some of the stretch. So you decide where you want to pinpoint the stretch. Now, if that IT band is short and tight, it's not just the band, it's the muscles that attach to it. TFL, glute max, they're abductors. What are you going to resist? Abduction. So let's do this in a triplanar. You're going to push your leg up and out toward that wall. Ready? Go. Toes out. Lateral rotation, glute max, and relax. Now I'm going to cross again. How are you doing? Good. If I get the knee, if the knee is more of an issue, I might want to make sure that knee is locked straighter. If the knee's buckling, lower the leg a little bit. Come down, decide where you want to focus. Feel that pull? Okay, push your foot up toward the ceiling there. Give them something to aim at and relax. So I'm adding the myofascial component of the weighting, taking up the slack, holding. This would work even better if I wanted to add some traction. Can you see that my position would be more effective? Feel a difference?
Less painful.
Less painful. That traction really decompresses the joints. People love it. And then gradually working into internal rotation, adduction, extension, etc. Now, if the other leg's popping off the table, sometimes I put a big Velcro strap to hold that leg down. If I need an extra hand and she's so tight that the pelvis really pops off the table, Velcro strap right across the ASIS as it wraps around the table. Velcro, take me 2 seconds to lock that in. So I have an extra set of hands. Any question on the leg pull? I could stop anywhere along the leg pull line. Like say she had a piriformis syndrome based in my exam and is creating a sacral torsion. I might decide, let me get more piriformis. When you flex the hip, the piriformis, which is, as you know, an external rotator, it becomes a horizontal adductor when the hip is flexed. So I'm going to cross your leg. You feel some stretch back here, let me know.
Right there.
Okay, so right there, so I'm going to resist horizontal abduction. Going to push your leg up toward my hand. Good, feel that pulling back here and relax. And if the hip's picking up, stabilize it. How's the stretch? Good. Now, what do some patients complain about when I have their hip flexed up like this and I start pushing? Impingement. Right, so you need to evaluate. If I didn't eval with her before, as I should have as a real therapist, I would have identified, I can't flex her an adductor, she's going to impinge. Maybe I would have done an impingement release first. Okay, one of those like inferior glides of the femoral head and all that other stuff. So any of those things you can do. But you can isolate an individual area and focus and see, I wonder if just after doing a leg pull and a piriformis stretch, did that sacral torsion change? Without doing all the other push on the sacrum, line them up here and there. Sometimes I get it to release just doing this without even doing the muscle energy. So I'm looking to see, gee, what is more necessary for a patient based on where is her greatest impairment? Where is the biggest restriction? What do I need to address? So let's go ahead and try the leg pull on a partner. Thank you. So the key with the leg pull, please make sure as much as possible you're applying that gentle distraction the whole time. Distraction, triplanar barrier, flexion, abduction, external rotation, into extension, abduction, internal rotation. You could do any order you want. It's up to you.
Neural tension also. Yep.
Neural is great for neural tension. I bring them to the edge of that. Tell me when you first get that tingling you're so used to. Oh, well, now I'm getting it in the side of my leg. Okay, I back it off a degree or two. How is it now? Barely there. Okay, let me do my release right there. I go right where the tingling starts. As the release occurs, oh, the tingling's fading away. I know I'm getting a release. Then I go a few more degrees into it. Say I go 10 degrees. Oh, the tingling's back. Good. Can we hold it right here? Okay, let's hold it. And sometimes I'll do that contract, relax, right at that angle. Sometimes I'll floss using the dorsiflexion and such. You could combine these techniques, and it's really great. if the tingling is becoming exacerbated and it's more tingling farther down the extremity, well, obviously it's too much.
Sure.
So you have to back off. Maybe they're not ready, they're still inflamed. Maybe there's other things you missed going on, like a severe herniated disc, and we should have done a straight leg raise first, you know, that kind of thing. Now, depending on your population, some patients are hypermobile, like my dancers. Some might more acrobatic type of athletes, and then you get the really stiff people. Some of my football guys, my power lifters, stiff, stiff, stiff. Now, please bear in mind, you're probably all familiar or learned somewhere along the line the PNF techniques. You can go into any angle of circumduction, any angle of the range you need. Some patients might require more extension. So how do you get more extension if they're supine on the table? Hang the leg off the table if you want to work more into extension. Or how about doing a leg pull with the patient in sideline? And you're going to do the leg that's on top. It's free to move now in all different ranges. If you are going to do a leg pull of the top leg in sideline, make sure the bottom leg is flexed at the hip and knee. So very often I'll have someone in sideline. I could get a great leg pull, a great arm pull. You know, feel free to try this on the upper extremity too, if you work with upper extremity patients. Don't just pull, add your post-isometric relaxation. Add your contract, relax muscle energy. Whatever angle, the three barriers you meet, in whatever direction, extension, adduction, internal rotation, say, have them contract the flexors, abductors, and external rotators. Then move them more into extension, adduction, and internal rotation. So use the same concepts throughout the leg pull, circumduction that we use for all the other muscle energy. Triplanar barriers, identify the barrier, have them contract the short, tight muscle, okay, away from the barrier, and then as they release, you can move them farther into the barrier. There will be a new barrier. If it hurts to move to the barrier, you back off a few degrees. Some people call that the interbarrier zone. Some practitioners do the muscle energy at the interbarrier zone. They bring them in the direction of the three barriers, but they back off a little. If patients have pain, you're backing off a little. You'll still get the correction. If you're doing a leg pull and you're getting them into a triplanar barrier where they're getting neural paresthesias, oh, I'm getting tingling and numbness down into my foot or whatever part of the leg that particular nerve is innervating, you could think about doing some neural tension testing and identifying, you know, what nerve, typically it's the sciatic nerve, what nerve is being pinched, where is it being pinched. If you find that the adverse neural tension tests are positive, which means if you're lengthening the nerve over all the joints over which it crosses, this basically, you could call that neurofascial tension. That's a myofascial problem, or shall we say more specifically, a neurofascial problem. So I will take that leg into whatever angle, typically it's, you know, straight leg raise with some internal rotation, some adduction, and you start to get that sciatic kicking in, it's going down to the side of the leg, sometimes the bottom of the foot. I'll tell the patient, tell me at what point you just start to feel that tingling, that numbness you're talking about, or that deep bone pain. For some patients, it's almost like a deep bone pain they're describing, like a deep toothache. Oh yeah, I'm feeling that now when you got to that angle. Okay, good. Let me back you off a degree or two. So I back off into the interbarrier zone a little bit, not the very end, just a little backed off. How is it now? Oh, it's barely there. Good. I'm going to wait for that to release to occur. I'll do my contract, relax. And then as they release, oh, you know, the tingling's going away. Good, now I take them farther into the motion. Oh, the tingling came back. Good, let's do the contract, relax at this new barrier with that little bit of distraction. And if something is making it worse, my neurological symptoms are getting worse. Oh, the pain is getting worse. There's more tingling, more numbness, and it's farther down the leg. Well, obviously, it's telling us we're doing too much. Maybe the nerve is inflamed. It's not time to be stretching it. Maybe I went too far. Maybe I should have checked to see if they have a disc herniation, and it might not be the best thing. Maybe I didn't examine carefully. So come back, reassess, find out what's going on. But I do find very frequently just adding that neural tension with the distraction during the leg pull with the contract, relax at that triplanar barrier of the leg pull, and it releases it quite nicely. And whether it's a leg or an arm, can't you do the same thing for carpal tunnel? But add your muscle energy, add your contract, relax all through. Wouldn't it be greater to release the tension in the connective tissue instead of the doctor having to come in and cut something? You know, it's just maybe get some more money, but it's not as interesting. I'd rather do this. I'll just mention also, I don't really have to demonstrate this because it's like really obvious, You could do a bilateral leg pull. Sometimes, especially patients with those sacral involvements, the lumbosacral involvements, I like to do just a general distraction, both legs simultaneously. Right in neutral or slightly flexed at the hips. And it's a wonderful decompression, so that's the one right here, wonderful decompression for lumbar spine. Once you're holding it, and I might spend several minutes holding that, which means I better get comfortable and have a good grip, because otherwise if you're not comfortable, you're going to get tired. That's a lovely release to do. Okay, next one we're going to do iliopsoas release, and this is actually a combination of two techniques. One is a myofascial release. We're going to take up the slack and hold with our fingers on the tendon of the iliacus and the psoas, right where that tendon comes superficial close to the hip. This is one of my favorite things to do before I do any muscle energy of lumbar spine, SI joint, or pelvis. I'd say like 99-point-something% of anyone I've seen with back, SI joint, or pelvic pain has had involvement of the psoas. Anyone find that psoas was not tight in somebody at all or not involved somehow at all with these problems? It's a multi-joint muscle. We're going to see, can we palpate the tendon and do a little, shall we call it muscle play once again, little muscle play of the tendon of the psoas and the iliacus, the hip flexors. Where they cross the hip, they become superficial and easy to palpate. So let's see if you can see it. Can you see that pretty well, guys? Okay, so the psoas muscle, psoas major and minor, are coming off the lumbar spine and the intervertebral disc. Now this model doesn't show it real well, but the fascias of the psoas attach right into those intervertebral discs. So it's very important if you're thinking about your like Thomas test stretch. We did some contract, relax, muscle energy for that to release some of the hip flexors. If you remember, I mentioned to you yesterday, you don't want a real strong contraction of those hip flexors when they're in a hyperextended position, because it starts pulling on the attachments where the psoas goes into those discs and could ultimately cause some damage to the disc if you have a strong contraction and some weakness or tears already in the annulus. So very careful with that. So psoas, some people are trained from a myofascial perspective. Okay, here's the psoas muscle. It's coming down in front of the SI joint here, and it's crossing over the hip joint just medial to that ASIS. It's wrapping around to, and they don't show you the whole thing here, but it goes to that lesser trochanter of the femur. So here's the tendon coming down, lesser trochanter, superior, posterior, medial femur, be attaching there. And of course you have combining with it the tendon of the iliacus. So iliacus muscle comes from the internal iliac fossa, the bowl. It comes down and it's actually cut in this model, but it connects directly into the psoas. So right in front of the hip joint, you have the conjoined tendon of iliacus and psoas muscles. This is a nice spot to palpate to see. If I get in and palpate, put your fingers about a finger width or two medial and inferior to the ASIS and palpate. The conjoined tendon of iliopsoas comes superficial here. And where you see where it comes down and crosses the hip, I'll kind of pull it medially, push it laterally, push it up, push it down, push it in all directions around an imaginary clock. Which way is it restricted? Where is the barrier? Is the barrier superior glide of the psoas, inferior glide, medial glide, lateral glide? Which direction? Find a direction it doesn't glide, take up the slack and hold it, applying just pressure in that direction that you felt the barrier, the restriction. When it softens, it feels like your fingers just sink in, not because you're pushing any harder, but because literally the muscle's softening. It's literally melting down and softening. What's happening inside with this myofascial, the collagen of the connective tissue is actually softening and melting down. It's becoming less viscous and more fluid. And also the little, what we call crosslinks between the collagen fibers, the proteins in the fascia that got literally stuck and bound together with fibrosis, you're breaking the covalent bonds between those collagen fibers. So you get some actual change in the connective tissue. Wait till you feel that change occur. And that time, that softening of the collagen, that melting down of the viscous nature, the ground substance in the fascia, that takes that several minutes, minute and a half to 2 minutes average to happen. So wait for that. So we're going to go in. Some people will come in for the psoas and they'll tell you, go through the belly and strum on the psoas. What are you pushing on if you go through the belly if the psoas lives all the way in the back there? How about your guts, right? Intestines? Do you think you should be strumming on people's intestines? What essential vital organ is embedded in a big fat pad in front of the psoas, being protected by the psoas? Kidney. So another reason I don't tell people go in and start digging, because what are you compressing when you're doing your friction massage to what you thought was the psoas? The intestines and the kidney. Unless you know how to move the kidney out of the way, which you can learn with visceral manipulation techniques or certain types of acupressure massage, know how to do that. Then you can get back there. But until then, let's address the tendon. So feel on yourself, please feel your ASIS. Put your fingers just inferior medial to it. Flex your hip. Feel the tendon active as you flex the hip. That's how you find it on a patient. So go ahead, get your person, and this can be done side lying, it can be done supine. Get your patient down. I'm just showing you here in supine. Palpate. Let's just get this on here. Medial inferior to the ASIS. I generally like to be on the same side, so I'm just going to turn this around for the sake of the demonstration. ASIS, a little medial inferior. Here's a psoas tendon. What happens if I push it medially? What happens if I pull it laterally, up, down? Which way is it tight? Oh, this guy's tight towards 8 o'clock on an imaginary clock. Take up the slack and hold. You can put the leg in varying degrees of extension based on patient's comfort and how much stretch you think they could tolerate. So fingers medial inferior to ASIS, find the tendon. If you're not sure if you have it, ask them to flex the hip a little. The tendon becomes prominent and palpable as they flex the hip a little. Good. Let the leg be relaxed. So the leg of the side you're working on, don't have them holding it up. Put a pillow under it or let them just lay it down flat. If they're comfortable with laying flat, you get a better stretch. If it hurts for them to lay flat, oh, it hurts my SI joint to lay flat. Okay, no problem. Let me put a pillow under your leg. Let me hold you up like these lovely people are doing. If the psoas is really, really killing them, sometimes you hit this, there's a trigger point there, they jump clear off the table. I see it all the time on patients. Then we could do what's called a little counter strain. So if you see, you could put the hip at 90-degree angle or so, or flex it up 90 or above, and you take the tension off the psoas. You could easily dig in, do your release very nicely if the hip is flexed. The muscle's in a short position, it's relaxed, it'll release its tension. If you're not sure you're on iliopsoas tendon, have them do a little flexion. You feel the tendon become prominent and palpable. Many people are ticklish here. Big trigger point in the psoas. Tickle takes the same spinal thalamic tract as pain to the brain. Guess what tickle is? It's a pain. Psoases often take a couple minutes to really soften. It's really worth it. If your patient is presenting with an anterior pelvic torsion, an anterior innominate, or a flex sacrum, you absolutely better do a psoas release, right? Because those tight hip flexors are contributing to that anterior innominate, so you need to do the psoas release. Now think about doing some of your contract, relax, or muscle energy PNF simultaneous with the myofascial. So if you put your patient in that Thomas test position, or in other words, extend their hip to the point of a stretch with one hand, the other hand you could be planting that iliopsoas tendon. Do your release. Which way is that tendon tight? Push it superior, inferior, medial, lateral. Which direction was the barrier? Plant the barrier, hold it for your myofascial stretch while you then add contract, relax. Contract the hip flexors, relax. Oh, let me stretch you into extension. Okay, repeat 3 to 5 reps. It's a lovely thing to combine. One of the things I do most commonly is combine myofascial with muscle energy together. And not just for lumbar pelvis, whether it's a frozen shoulder, whatever. Really, really works great. And this is where we go deeper. So patients who can't tolerate any deep work or who bruise easily, naturally you're not going to dig in. So it's deep tissue work. I typically like to have lotion and stuff available. We're just going to kind of wing it here in the class. Some of these techniques you could do with or without lotion. Soft tissue mobilization cream. If you're dying for some lotion, there is hand cream in the bathrooms, I noticed. So if you feel you need a little bit of that, you can certainly avail yourself of that. And we're going to look at some circular friction and circular long stroking using the elbow. And I even show you how to use maybe a knuckle. So you could use elbows, knuckles. You know, people do this also with their fingertips, but if somebody's really tight, like most of the people I end up seeing, you kill your fingertips. So typically, we've been looking here at sacral torsions. We've been looking at patients who have lumbosacral problems that could ultimately impinge on nerves. Many times people will have big trigger points in the piriformis muscle. A reminder, piriformis muscle goes from on the anterior side of the sacrum, okay, lateral-most aspect of the sacrum. The fibers descend inferior-lateral to that greater trochanter. So we're thinking of fiber orientation, inferior-lateral. It's a deep muscle. It doesn't live alone. It has 5 neighbors, right? The other 5 deep lateral rotators. But then what's more superficial? Gluteus maximus. So you always remember what's the anatomy, what's the fiber orientation. We're going to follow a muscle from origin to insertion or insertion to origin along the fibers with our myofascial technique. Gluteus maximus superficially comes from the lateral border of the sacrum. Some fibers often go to the tailbone. Inferior and superior gluteal line just below the iliac crest. The fibers also descend inferior-lateral to the greater trochanter. These fibers tend to attach more to the posterior-superior aspect of the greater trochanter. As you know, other muscles attach here as well, like gluteus medius and minimus coming down. Those can also be affected. So if you're coming in here, we want to see, can we do some circular friction, would be the name of the stroke, instead of transverse friction that moves across the tendon, rub, 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 rub in the same place. We're going to be constantly moving through the fascial plane. What's the fascial plane? The spaces between the bands of muscle. So when you palpate muscles and you feel there are those taut bands, those guitar strings, instead of flicking the strings like we're strumming a guitar, we're going to try to feel the spaces between the strings. That's the fascial plane, where one layer of muscle has to glide past another. So can we feel in those layers and achieve some more glide to get some mobility and circulation in the fascial planes, to get some flexibility of the muscles? Now, of course, one of the key things that happens here is piriformis syndrome. Piriformis is tight or restricted because of tight lateral rotators. Okay, we want to start working on getting a little more medial rotation. I might warm up this area with this first. Now you're going to feel a little bit of deep massaging all along here, the border of the sacrum, going to the bone, and then we're going to get into the meat of the muscle here. Is that okay for you? Mm-hmm. So same thing, a palpate, where's the iliac crest? There's this PSIS, come inferior. And I could just start now with the circular frictions. You could use, I mentioned elbows because it's a bigger area, but you could start with fingertips and little circular frictions. And this is part of my palpation also. I'm working through the muscle, and I'll do the attachments first, the origin and the insertion, and see as I go along on any areas of abnormal tension. A little bit here, feel right here? So a little bit of a band right there at the superior pole of the greater trochanter. I might work that a little bit. How long? Until I feel it start to soften. So this is all, again, your palpation, your sensitivity to your palpation. A little bit right here too. So now fingers get tired. Sometimes I like to use a thumb over thumb. Thumb over thumb. Or a knuckle. Big MP, third knuckle. I could get that in there. Through a straight wrist, I could just lean my body weight, get the knuckle in there. More commonly, especially if you're working through thicker, deeper muscles, glute max, one of the largest, strongest muscles in the body, you might want to use your elbow. So say I traced out superior gluteal line, inferior gluteal line. I did all my circular frictions along the border of the sacrum. I did all my circular frictions around the trochanter. Now I could get in and see, let's go strip by strip through glute maximus into the piriformis using the elbow. So find your areas to work. So here's PSIS, sulcus. I want to come down into the muscle. I could feel muscle here. I plant my olecranon on my elbow. I take a stance, one foot in front of the other like a lunge, so I could easily right angle for the elbow. And there's a little band in there too. Is that okay for you? Mm-hmm. So I'm going to start with light pressure and gradually work deeper in as the tissues let me in. That starts to soften. Go to the next spot. So I could trace the attachments of the muscle, in this case the lateral border of the sacrum, and then I'll start tracing the muscle from the sacrum, and I'm stabilizing the pelvis because otherwise he's going to roll all over the place. He should have a pillow between his knees. Now I could get in, I could start working deeper into the glute. That's a good spot too. Yeah, so he knows we're in a good spot. And just work. Now notice I'm not all over the place with the elbow. I plant the elbow, I sink in, I'm working from my legs. So you don't see a lot of motion with the elbow. The motion is actually coming from my legs. And I'll work with my elbow layer by layer by layer. Sometimes I like to work with a knuckle, depending on the angle you're at for the patient. If I'm working with a knuckle, can you see that it would be better if I was up higher to get some leverage? So this angle is actually better for me for elbow. So you could use fingertips, thumb over thumb, fingers over fingers, circular friction, knuckles, the big MP knuckles, not the IP knuckles, or elbow, so layer by layer. The other one for the hamstring, let me just see, go prone for me. Can I show this hamstring?
Yeah.
Okay, good. Little lotion. This one, a little better to use some lotion. I could do some circular friction without lotion, just to show you the same thing. And this could be any muscle, but generally for those bigger, denser muscles, it's really nice to be able to use elbows and knuckles. Scoot down just a touch so your feet are a little more comfortable over the edge. Good. Hamstrings, you have attachments, biceps to the femoral head, posterior lateral tibia, okay, semi-membranosus, posterior medial tibia, semi-tendinosus, all coming from ischial tuberosity. That wraps around to the anterior medial proximal tibia. I'm going to trace the muscle insertion to origin. So I like to go toward the heart when I'm working on an extremity, circulation reasons. So I can start to see where the hamstring's tight, palpate, get my circular frictions here. I could just plant my hand circular friction through a thumb. So just between where that IT band comes back and the lateral hamstring, many people get tight, that IT band gets plastered to that lateral hamstring. So I could work thumb, I could work knuckle. Sometimes I'll hold my wrist to make sure I'm nice and stable. And I'll trace up, all the way up to the attachment. If I'm working with my elbow, I'm certainly not going to push in the popliteal space. I assume you know where nerves are, superficial, and blood vessels that shouldn't be squished. Oh, we got some nice little taut bands right here, right here. You ever pull that hamstring?
Oh, several.
Oh yeah, okay. So it could be thumb over thumb to protect my thumbs and circular friction. And again, for the demo, I'm doing this quickly. With a patient, I might be here 10, 15, 20, whatever seconds. That starts to soften, I move on. In the next spot, that starts to soften. Oh, it got tight, my finger's getting tired. Let me try an elbow in there. Elbows roll all over the place easily, so find the space between the tendons with your thumb, get your elbow in that space, and then a nice little circular friction. So I'm just leaning into my front leg, so this is no effort. I could get deep with no effort, but I sink, 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 sink. There I feel my resistance. Now I'm going to start working. So I sink to the level of the resistance. How is the pressure for you?
Fine.
Fine. And he's okay. And I'm going to strip that all the way up anywhere I find those taut bands or those restrictions. You can try fingertips, knuckles, elbows are great. And the last one, if you wanted to get even deeper, with a little bit of lotion. In particular, if someone has like body hair and you start just stripping, you're just going to give them a shave with your fingers. So you want to have some lotion. And it'll feel like just a little bit of a stroking massage, and then I'm going to do digging and rubbing up and down, okay? So I tell the patient what I'm going to do. If anything feels like too much, let me know. So just spread out your lubricant so that you're not abrading the skin. And say I found, okay, right in here I felt that semimembranosus and semitendinosus, nice taut bands. I'm going to get between the bands and glide. So gliding, that's just effleurage and massage. That's my assessment stroke. I can feel it's really knotty right in here. Feel? I check in with the patient. Does he agree with me? Now don't miss, on a real patient, I'm going right to the ischial tube. I don't think he wants his on video right now, so you get the idea. We definitely want to go origin to insertion or insertion to origin. I could come up with an elbow. Make sure if you're using your elbow, you're on a big muscle group, lube up the elbow. Find where the tension is between those fibers. Got a nice line of tension right here. Get that elbow and just glide. So right angle elbow, glide. And now if you take your hand and just wave goodbye to the restriction, you're going back and forth with your olecranon, back and forth, back and forth. You're in the fascial plane between those taut bands, taut cords of a muscle. It's easy to flick over it like this. That's not what we want. We want to glide toward the heart for circulation and back and forth and wave goodbye to the restriction. And I might have to move my body a little up to work up the leg. How's the pressure with the elbow?
Okay.
Get right in there, right? So a lot easier, and I'm just taking my time as the tissue lets me in. If the tissue's real tight, I might go even more slowly. So time it, you'll go by feel, and you're working your way up. So finger over finger, I could go back and forth. Very precise, I get my middle fingertip of my right hand. All the other fingers are just backing it up. Very deep, because I have a single finger point. I could have gone thumb over thumb. Also deep if I'm using the point. And look, Ma, no nails. Okay, nails, you give them acupuncture, you could charge extra for that. Thumb over thumb, or knuckles. I could kind of work my knuckle back and forth. Same thing. So elbows I find easier for the larger muscles. Bend at a right angle for the elbow. Point your hand the direction you want to go. I'm going up the leg and pointing my hand up the leg and gliding. And when you loosen this up, if he had that posterior ilium on this side, I'm going to do this hamstring release before I do my correction with my muscle energy. I want this to hold. And I want to make sure, gee, if the muscle was simply tense, holding them there, I don't have to do that correction. It might have corrected itself. So these are things, you'll evaluate, you'll decide on people, especially if they're chronic, you're going to need the soft tissue work more often. If it's a real new, fresh posterior rotation, he fell on his butt or something, it might correct that quickly with a muscle energy technique. So it's up to you. Decide based on your clinical decision making, based on your exam. Go ahead and try those techniques, please. So we're making sure we're focusing insertion to origin or origin to insertion. We're circular frictioning the origin of the muscle, the insertion of the muscle, and all the nooks and crannies within the muscle. The spaces between the taut bands of tissue. So here we're doing some circular friction myofascial work. We're working in the fascial planes between those taut guitar strings of the hamstring. So she was digging. Show us where it was sore. Reproduce that for us. Okay, stop right there. So there we go. We got a jump sign. If the patient's jumping because you hit a trigger point, you don't just drill into the trigger point. Trigger point's typically in the taut cord of muscle. You'll feel like a thick fiber of a guitar string. So instead of digging on that fiber, I'm going to move and work, say, lateral to that fiber with my circular frictions. I'm going to work medial to that fiber in the space that my fingers naturally sink into. The fascial planes, little spaces between the fibers. And you can work and strip up both sides of that taut cord. And if you come back, you'll find, oh, the trigger point's melted down. And that's one of the nice things about using this circular friction, whether it's, fingertips or knuckles, thumbs, elbows, will be very effective. So we won't drill the trigger point, we'll work around it. We'll make nice. Is there something that you found you thought could be better about this seminar? Is something that you really liked about this seminar? You have an evaluation form. Please take that out right now if you've not already done so. Complete the seminar evaluation form. If you're doing this as an online course, you'll see that evaluation form separate, so look for that. You need to complete the evaluation form in order to get a certificate. Any questions before we move on and tie everything together today? No, we're moving, we're shaking. Okay, well, thank you very much for participating. Again, my name's Teresa Schmidt. It's been an honor to share the days with you. Enjoy the work, and again, if you have questions, feel free to come up and ask me or email me later if it occurs to you. Thank you, guys. God bless.
Pond5.com. Pond5.com. Pond5.